to the next caller with the last three digits of 122. Please slowly pronounce and spell your first and last name. You have 2 minutes to speak. You are now unmuted and may begin.
Good morning, and thank you, Speaker Frierson, members of the Assembly. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I'm the Director of Government Relations for Dignity Health St. Rose Dominican. We submitted comments for the record, and I'm just reading these remarks on behalf of our leadership this morning. In the span of 3 years, Southern Nevada hospitals have provided expert care to our community through two large-scale emergency events: the tragic October 1 shooting and the current COVID-19 pandemic. Amidst this chaos, our hospitals never hesitated to answer the call. Our doctors, nurses, and facilities are always there for the residents and visitors of Nevada. We understand that this is an unprecedented time and that difficult decisions must be made. However, the proposal that considers balancing the budget on the backs of an industry actively working to keep thousands of Nevadans alive through this pandemic seems irrational. From a distance, some may assume that having many patients come through a hospital's doors means that we have been doing financially. That is just not the case. While our ICUs and inpatient rooms are close to full, the financial model that keeps us in business has been pushed off the cliff. Elective procedures or surgeries are down to approximately 18.7% of what they were in February of this year. And in addition, people are just plain scared to come to the hospital, which means our ERs have been empty. Emergency department volume is down by approximately 35% of what it was in February of this year. To offset some of these losses, we have seen federal relief funding come our way, but it only minimizes the impact. We have no idea what the next 6 months hold for us from COVID-19 or the federal government. Will we be overrun with ICU patients? Will the virus exceed our capacity to care for our neighbors? Will we be able to keep our doors open? We know that people are suffering, some from the virus itself, but many more from the economic fallout of the virus. As the only not-for-profit faith-based health system in Nevada, we have made the decision not to bill patients for COVID-19 related care. The recent revelation that the state of Nevada is considering reductions to an already anemic level of Medicaid reimbursement funding is disheartening.
And ma'am, you're beyond the 2 minutes if you could wind down.
Would take us backwards. Okay, and I did submit these for the record, so please take a look. I appreciate your time. Thank you.
Thank you very much.
Next caller with the last three digits of 179. Please slowly pronounce and spell your first and last name. You have 2 minutes to speak. You are now unmuted and may begin.
My name is Stephanie Goodman, Goodman. I am the Executive Director of the Dr. Robert Hunter International Problem Gambling Center here in Las Vegas. Now more than ever, we feel the impact and the importance of gaming in our community. Nevada has established itself as the thought leader in gaming, and recently we've made great strides as the thought leader in problem gambling. The impact of this lockdown has been an economic nightmare, and of course there are so many needs that you all must consider. I would just ask that you not discard problem gambling as a discretionary need. 6% of our population is affected by this debilitating addiction that is a published DSM-5 addiction and lives in the same part of the brain as alcohol and drugs. We help people every day with our intensive outpatient program. These are mothers, sons, daughters, professionals. These are all working Nevadans. To eliminate our funding by 75% is an insult not only to our state, but to the people who live here and support the gaming industry. We understand that cuts are necessary. I would just ask that you not make a disproportionate cut to the programs that support those who do not gamble for fun. I will close with an anecdote from our founder, Dr. Robert Hunter. He used to say, if you build a beautiful ski resort where everyone is enjoying the slopes and the amenities, you better have a small clinic at the bottom of the hill to treat those who sprain an ankle or break a leg. The problem gambling community is that small clinic for Nevada's problem gamblers. We need you to please keep us funded with a workable deduction so that we can continue helping Nevadans. And as a side note, specific to Medicaid filling the gap for funding, Medicaid is not a viable option. The majority of our clients do not qualify. And additionally, Medicaid rarely reimburses for problem gambling without the presence of a comorbid addiction such as alcohol or drugs. I appreciate your time today. Thank you so much.
Thank you.
Next caller, please slowly pronounce and spell your first and last name. You have 2 minutes to speak. You are now unmuted and may begin.
Yeah, hi. My name is Jonas Waldo. And
If you could spell your name for the record, please.
I'm not sure. Can you guys? Yonas is the first name. Last name Woldu. And then I want to thank you guys for allowing me to speak for 2 minutes. And so the main thing I'm into is the deficit. And I realize the deficit is a huge deficit. And one of the solutions I was thinking about to share with you guys is to do some kind of state bond or city bond, where basically the public, the casinos, individuals can invest in this bond and generate the shortfall that Nevada has. And then in terms of the interest to pay out, it could be a bond, could be for about 3 years or so. In terms of the interest to pay out, that could be collected by DMV. It could be different taxes from the DMV, things like as new residents come in and so forth. Any way you can to generate income, but the benefit is you don't have to generate that much income relative to the shortfall. So the public will have a vested interest, the casinos will have a vested interest in keeping the city going, so that way you guys can survive for 1 year or so. And then the idea is just to keep in mind that this pandemic might last until September of next year. That's just the reality of the situation, the way they talk about the vaccines and everything like that. In the meantime, just recognize Vegas could be the hub of the pandemic. So it's very important that if you guys open too soon, just recognize that we could be spreading the virus dramatically. So it's important that we can fund people, the budget, and everything that way. I think people will invest in that if the money is right for them as well. And then in terms of education, school's going to be opening up. It'd be smart, wise to invest in in-home schooling as opposed to opening the schools right away until this pandemic gets resolved. And then other than that, that's all I have. Thanks so much for the opportunity. Oh, one more thing, property tax. In terms of property tax foreclosure, the policy should probably change on that a little bit to attract more people to come to Vegas in case something happens to the point where we experience what we experienced in 2009. That way, more money will flow back to the state. And so that's all I have for now. Thank you, guys.
Thank you very much.
Next caller with the last 3 digits of 117. Please slowly pronounce and spell your first and last name. You have 2 minutes to speak. You are now unmuted and may begin.
My name is Michael Guss. My name is spelled Michael, Guss, 2 S's as in Sam. Many years ago, in 2012, I wrote the Northern Nevada Economic Development Plan and was involved in tax incentive packages that did significant development in Northern Nevada. Piggybacking off of what the last person said, one of the things I know is those incentive packages are generally 5, 10, in some cases 20 years. And if you paused those incentives or even have them for the year, you would get a significant amount of revenue, especially the Governor's Office of Energy, but also the Governor's Office of Economic Development has given out a substantial, and I mean substantial, it might even be close to the deficit amount of tax incentives in this state over the past 10 years. And some of them are still being given out today. If you pause to a business that has a factory, let's say at USA Parkway, and if you say, for this year, we're going to have 50% of our revenue, or 50% of the incentive is going to go away, and then you give them a year on the back end at the full amount, they're getting more over the long run anyway, so they'll just refinance their bond. It's raising significant revenue for you now. And frankly, if a business isn't willing to step up at the moment and help us so we don't have to cut Medicaid, which has saved people's, that I know's lives, that we don't have to cut mental health funding, which we need more than ever as people are isolated, and so that we don't have to cut education funding in what is already one of the worst education systems in the country, whether we like that or fact or not, then that would be a lot better than just solving this with cuts across the board, which seems to be the solution that's being proposed at the moment.
And sir,
And I would just
you're beyond
encourage you
2 minutes. If you can wrap up.
Yeah, I thank you for your time. It's an honor to speak to you. And I wish you the best.
Thank you, sir.
And next caller with the last three digits of 546. Please slowly pronounce and spell your first and last name. You have 2 minutes to speak. You are now unmuted and may begin.
My name is Jenny Stokes, JennieStokes. I'm an advocate for people with disabilities. I was born with a congenital disability that caused the amputation of my right leg. Since I was a toddler, I've relied on a prosthetic leg to walk and live my life. Due to lack of affordable health care and outrageous expenses of prosthetics, approximately $50,000 or more, I've received necessary assistance from a variety of sources to provide me a prosthetic leg. Due to already limited funding for these services, I utilized the leg below the standard I needed as a child, thus causing severe hip degeneration and unbearable pain. As an adult, I rely on Medicaid to help cover my prosthetic leg. Recently, I was forced to make the impossible decision between seeking pain management treatment and having a functional leg to meet my needs, because Medicaid did not cover both. This is before your proposed cut. Now you are asking me and many other Nevadans to make even harder and more damaging choices because you're choosing to cut Medicaid by $500 million. Not only are you asking me to give up my prosthetic leg, which allows me to work, you are asking our disabled community, mental health recipients, and elderly to give up necessary life-sustaining supports they rely on. 42% of your total proposed cuts are directly affecting Nevada's most vulnerable people. These cuts mean seniors who rely on in-home services won't have assistance with showering. This means cuts to housing for our mentally ill citizens will result in homelessness. These cuts mean people with intellectual disabilities and their families will lose crucial supports for their basic human needs. I'm asking you to make another choice. I'm asking you to find a way to raise revenue, make cuts somewhere else where you aren't horrifically affecting the lives of our vulnerable Nevadans. We are not Nevada strong until we stop treating our people with mental illness, people with disabilities, and elderly like second-class citizens. Please do better. Thank you.
Thank you.
Mr. Speaker, there are no more callers in the public comment lobby.
Thank you to BPS. We will move on our agenda. I believe the first on our agenda for today, and probably the lengthiest, is Department of Health and Human Services budget reduction proposals. And we should have Dr. Richard Whitley, Director, and Suzanne Byerman on the queue.
Hello, Mr. Speaker. This is Richard Whitley.
Good morning,
Can you hear
Director.
me? Thank you. As I said, for the record, this is Richard Whitley. I serve as the Director for the Department of Health and Human Services. The department has in State General Fund, and I have provided a presentation framework to go over. On page 4 of my presentation, you can see that the reductions for the department total $233 million. The department approached these really difficult decisions by prioritizing direct services and using really the CARES Act funding wherever possible. These are tough decisions that we're making in our department because they impact the lives of people. And coming out of the last session, we really made great gains in the healthcare system in our state with an investment in mental health that was the largest in a decade. And overall, the largest investment of general fund in the Department of Health and Human Services. But if you overlay the challenges to the Affordable Care Act, and then most recently the COVID pandemic, we're faced with a lot of challenges. It's as if on one hand, we're reducing services, and also needing to deliver them at the same time in a real, what I have to say is a fragile a fragile healthcare system. Um, our main goal concurrently with these reductions is to protect the public's health. I do need to say that under the federal emergency declaration that we have benefited from the enhanced federal medical assistance percentage, or FMAP. This is the federal share to Medicaid. Additionally, we've benefited from the use of the coronavirus relief funds. But I guess I'll also add that when we looked at these reductions, we were able to do the cuts without eliminating any filled state positions. So if it's okay with you, if you turn to page 4 in my presentation, it would be my intention to go over each division's reductions and pause for questions after each, if that is your preference.
Thank you, Director. That would be fine.
Thank you. Starting with my office, I have 2 reductions. We plan to reduce the $3 million in family planning by $1.5 million. We'll work with the subgrantees in this case to maximize those resources and support them in billing where possible. The second one is reduction in my office is the Healthy Nevada funds. These funds are generated from tobacco settlement. We propose sweeping 16.8 million from a balance of 37.3 million, and this would leave an ending balance of 20.4 million. This will not impact any of the currently funded agencies for this fiscal year. Our intention would be to build a budget based on that end balance and present to the next legislative session. I'd be happy to answer any questions about those 2 proposed reductions.
Sure. First, members on the floor, are there any questions? I don't see lights thus far. Are there any questions on the floor? If so, light up. One minute recess.
1 minute recess. Thank you.
All right, Assembly will come back to order. We have questions for operations within the Director's Office. Assemblywoman Neal.
Thank you, Chair Frierson. So I had a question, Director Whitley. So in the impacts that you're going to be occurring in the family planning piece, how can you explain, give me an example of how the billing capabilities will work with the subgrantees, how they're going to try to include other funding sources to cover services?
Sure. For the record, Richard Whitley. I'll give an example. I think that best illustrates the agency that receives the largest amount of funding is Southern Nevada Health District. They are also a federally qualified health center, and the service is reimbursable from Medicaid, and so they can in fact bill for it. I think that sometimes having a categorical grant for a service does allow some flexibility in terms of maybe providing an immediate service without having to do eligibility. But we've worked really hard at putting our eligibility workers in the community at different locations, and so I do feel comfortable, even given the recent action by the Supreme Court with some supports of allowing employers to not cover family planning services, that we can target the most vulnerable, and we can support those agencies like Southern Nevada Health District that already bills for Medicaid and for services. We can support them in their billing.
So just a quick follow-up, Speaker.
Follow up.
So in regards to the family planning, do you think that there are going to be any issues? Because I know that there's been a consistent effort, specifically like in my district and the community that I serve, around STDs and trying to build those coalitions around with the churches and different things. So do you think that those will continue in terms of, you know, the planning services and trying to make sure that care occurs?
For the record, Richard Whitley, I think it does impact it, and you make a good point. I think that what family planning often serves as is an entry point for primary care or whole health. So, you know, for example, a woman may enter for family planning services and in the course identify other health conditions. And so if we weren't in this financial crisis, this would not be a cut that I would put forward. But the fact that it can be reimbursed, we are going to have to extend ourselves to work with communities to not go backwards in the work that's been done, particularly with coalitions.
Thank you, Speaker.
Thank you. Assemblywoman Titus.
Thank you, Mr. Chair, and thank you, Director Whitley, for being here today and going over some of these really tough decisions for the overall health of Nevadans. I'm concerned about the family planning services reduction and possible unintended consequences, and I appreciate my colleague from the South asking about the potential for the health and infectious disease in her constituents and throughout Nevada without having family planning. But along that family planning also comes, literally, family planning means you plan many things. You plan about health, you plan about reproductive health, and some of those access to care. And I'm just wondering, one of the things I'm looking at, and I think we all are, the unintended consequences of some of these cuts. So that if we cut family planning, are the access to perhaps birth control and prenatal care involved in that? Because we know that there's unintended pregnancies, and sometimes even if the pregnancy is intended, without access to health care, there's no prenatal care. Without access to prenatal care, we also know that there's premature births and not always healthy births, and those births then end up in the NICUs in Southern Nevada and Northern Nevada. And with looking at these sweeping cuts that we're doing, are we cutting in one place and then we're going to cost more money down the road because of the lack of prenatal care? Then we have premature births, and then we can't find some place to take care of the citizens of Nevada. So could you clarify that for me?
For the record, Richard Whitley, I mean, I don't know if I can say it any more clearly. I think that you laid out that family planning is an intervention point. It's a prevention point. It is more than a euphemism for birth control. It is truly planning a family, and so it does serve to upstream intervene and prevent more costly health outcomes. And so it will have impact. And I would like to say I'm not presenting any of these reductions with support that they do good things. I mean, within the constraints of, when we get to the Medicaid budget and talk about reductions, we are very limited in where we can make reductions. The task I had was to achieve a 14% reduction, and so it's hard because I don't feel like I can defend this in the same way I would defend adding a program that I put thought into adding. I have put thought into, and I own all of these reductions and eliminations in this budget. But by no means is it ideal or is it without consequence.
Thank you, Dr. Whitley. Actually, as a follow-up, Dr. Whitley, I think it would be fair to assume all of these cuts are cuts that would result in increased expenses down the road that we're going to have to make up for. I think it's echoing your sentiment that this isn't something that you want to do, but would it be fair to say that all of these are cuts that are going to result in challenges down the road?
For the record, Richard Whitley, absolutely.
Thank you. Assemblywoman Cohen.
Thank you, Chair. Director, your department's it's vast. It's always shocking for people who have never really looked at all the different departments within HHS to see how many different divisions there are. And so with that, I'm not exactly sure because I'm not on the money committees about where this falls, but looking at your presentation, I'm thinking this is the right place. In the director's office highlights, is this where I would be the place to ask about PPEs for all of the department's employees, and are they getting enough PPEs, and are they going to be able to have access to that, or is that going to be part of the cuts? Are they going to be forced to provide any of their own, or are we going to be able to send them out into the communities with proper PPEs?
For the record, Richard Whitley. I think this is an appropriate place to ask the question. I mean, we have, as you said, we provide multiple services. As you know, vulnerable populations in congregate living are the highest risk for transmission of COVID-19. We have multiple with 24-hour facilities, some with less risky populations, some youth with juvenile justice, but certainly our intermediate care facility with people with disabilities and our psychiatric hospitals that range the lifespan and as well as underlying health conditions are our highest risk. We hold our facilities to the same standard as the community, and in fact, they're regulated to the same. We are not reducing PPE. You know, there is a national shortage and a priority listing for that the feds in terms of the stockpile that the state gets. And so how those are distributed, I would say the most vulnerable, I think our 24-hour facilities, our hospitals, we've done everything possible to make those available, including our own staff. I think it's those providers that go into the home where they just in the priority listing for the feds that they fall into to a lesser priority. But our staff we are not reducing any budgetary item for protective equipment for employees.
Assemblywoman Benitez Thompson?
Thank you so much, Chair. And so my question on the Fund for Healthy Nevada, and I just want to make sure I'm understanding this right. So the plan is right now to start that 60% of the dollars that go into, I'm sorry, the Fund for Healthy Nevada, the funds that go into Healthy Nevada, which is the 60% from the MSA program. The proposal here would be to keep these funds, keep pulling these back to general fund through 2023. Is that right?
For the record, Richard Whitley, yes, that is correct.
And then can you tell me a little bit, if should we have the very good fortune to return to a little bit of normal, should we have the very good fortune to have revenues tick up, is there thoughts from the department that you could share for us about some of these services that might be able to be restored? And I wanted to ask that at the top so I wouldn't necessarily have to kind of ask it as we move through all of the budgets. If we could get that out on the record, I think that would be helpful.
Sure. So I think I might have heard two questions in there. I think one specifically to the Fund for Healthy Nevada, the tobacco settlement dollars, and then just overall for our department, if we were to be able to add some things back. I'll tackle the Fund for Healthy Nevada. So as I said, our ending balance will be 20.4 million. So we'll build our budget to fund to the 20.4 million and come before the legislature. And that, as you know, the Fund for Healthy Nevada primarily funds nonprofits, which are also very vulnerable right now, and make up a safety net of service provision for things that aren't covered or reimbursable. And so we aren't sweeping all the dollars. We are keeping dollars, the 20.4 million, and we'll build the budget accordingly. As it relates then to any priorities for adding back, I would say starting with Medicaid, and you'll hear Medicaid's budget, but it's hard to pick any one service because you're going to hear from Medicaid that the federal government has mandatory services and optional services, and optional is the worst term probably, because if you're an amputee, the prosthetic service is not optional. If you don't have teeth, adult dental is not optional. And so I can't rank them, honestly. There's just no way to rank a direct service that people need, but I can and have put them together in terms of services within Medicaid and what the costs would be, and what the utilization is. And those would be the things that, and I'd be happy to share that document with you. We've done it internally as a way of getting at our 14% reduction, but it's just, I don't know how to do that other than to demonstrate to you what the services would be that we would be eliminating as a higher priority over those that we're limiting in some way or reducing a rate. The elimination of a service to me is very impactful. On the other hand, the balance of reducing a rate, if that actually decimates a service system because providers are unable to provide and they leave or go away, that it achieves the same thing. So it's very difficult to prioritize in any sort of ranking order if that's what's ultimately needed.
And then, Mr. Chair, I had a quick follow-up, and thank you so much for that. With the funds for Healthy Nevada, those are mostly dollars that are granted out to nonprofits in the community. Those are carefully selected. There's the big community need assessment that the department engages in to determine how those dollars are going to be used. Can you talk a little bit about the conversation with those nonprofits? How are we notifying them of the loss of these dollars? We're on July the 9th right now, so did they receive potential notification July 1st, or are they receiving notification at the end of July for August? Could you talk a little bit about that information sharing to the grant recipients?
Sure. For the record, Richard Whitley. As it relates to the Fund for Healthy Nevada, we won't be reducing any of the current awardees. It will be, the real work will be the committee looking at the landscape of needs in our state and prioritizing for the next RFP of how do we best invest these dollars. But the current awardees for this funding, we're not proposing to have to modify their existing contracts and reduce the amount. We're proposing the sweeping of reserves.
Thank you so much. These dollars that we're sweeping are there won't be a program impact. Is that what my takeaway from that is?
For the Fund for Healthy Nevada,
yeah.
That is correct for the Fund for Healthy Nevada. We will need to engage the providers of family planning and modify. As you know, during the pandemic, much of primary care has been impacted, and so we have seen a reduction in utilization and with those services, and so the engagement will be with the different funding streams, the family planning. We will engage the providers and make adjustments to what their spending has been and meet that threshold of what the sweep would be of the 1.5 million of family planning.
Thank you, Mr. Whitley. I'm gonna clarify just because I think sometimes it's public information that I'm easily confused. So, but I was thinking specifically of the tobacco fund settlement dollars. So that piece of funding with the Fund for Healthy Nevada, kind of that timeline of communication to those specific grantees, and how when those services will be impacted. So, when you were talking about sweeping reserves, you didn't mean reserves in the Healthy Nevada Fund?
It's reserved, but it's not current funding that's obligated. So we will not be reducing current subgrants or contracts with awardees out of the Fund for Healthy Nevada. What we will do is plan going forward for the RFP on how to best invest that 20.4 million, but not in fiscal year 21.
Thank you. That's what I was missing. I appreciate that. So for 2021, it's going to remain the same. So we will essentially see the service difference change in 2022.
Yes.
Thank you. Okay, thank you. I appreciate that.
Thank you. Assemblywoman Neal.
Thank you, Chair Frierson. So, Director Whitley, I just had a quick question. So, I wanted to ask about the plan going forward and how are you guys envisioning, because I heard everything, which is you're going to be ranking and prioritizing, you're going to be looking at the reduction, the utilization of services going forward. But is there a conversation in the strategy going forward to start looking at the federal grants or other grants that maybe can play a role in beefing the services in 2022 that may be impacted? Because what I heard you say was that we're going to have to look at the needs again and then scale the 20.4 million and see what we can pay for, right? Like, did I hear that correctly?
For the record, Richard Whitley, exactly. I think to give an example, one of the initiatives that was funded out of and approved by the legislature last session was a investment in telehealth, which the awardee was Nevada Health Centers, and the partner to them was the Clark County School District. Certainly couldn't have predicted how timely that would be, but one of the requests that we've had is that providers, including primary care, but certainly the federally qualified health centers, could benefit from additional support in telehealth capability. And so that's an example I would give, that looking at the changed landscape, which probably will be even different 6 months from now, that we look at that and have that as a consideration when we reestablish health priorities on how these funds can best be used to serve the communities and the vulnerable population.
Thank you, Speaker.
Thank you. Any other questions on the director's office specifically before we move on to the next section? I believe next is aging and disability, Dr. Whitley.
I'm not a doctor, just I'm a director.
You've been a doctor to me, Director, for a long time, so I appreciate it.
All right, thanks. So the next budget really is our Division of Aging and Disability Services, and Dina Schmidt, the administrator, is going to go over what those reductions are.
Good morning, Speaker Frierson and members of the Assembly. Dina Schmidt for the record. I serve as the administrator for Aging and Disability Services. And as Director Whitley has highlighted, these are some very difficult decisions we're having to make. But I'll walk you through some of the areas that we've been able to identify opportunities for savings. Several of our caseloads, we anticipate pulling those caseloads flat and freezing the caseloads. The first one being our Autism Treatment Assistance Program. This program provides evidence-based services to children with autism. We currently have 892 children receiving the service, with 191 on the wait list. And we'll be holding that caseload. In our personal assistance program, which provides in-home supports to people with physical disabilities, we'll be capping that caseload. That program currently has a caseload of 103 individuals, with 23 people waiting for services. In our community options for the elderly, this program provides also in-home supports, but for those elderly clients needing in-home supports to remain in their home. That program currently serves 95 individuals and has 28 on the wait list. Additionally, we'll be holding our regional center supported living arrangements and jobs and day training programs at their current levels. Additionally, one of the other areas where we will be deferring our provider rate increase that was approved in the last legislative session for our supported living arrangement services. For those that are not familiar with supported living arrangements, those are services that are provided to individuals with intellectual and developmental disabilities in order to keep them in their community living as integrated as possible. Additionally, we're going to be reducing our respite services in our developmental service program from $125 a month to $100 a month. There's currently 1,769 families receiving those services. And when I say receiving them, they're approved for the service, but not all of them utilize the service. But we will be reducing the monthly amount to those families. Our family preservation program, those are payments to families with children who have severe and profound intellectual disabilities. They receive a stipend every month of $374. We'll be reducing that to $356 per month. There currently is no wait list for that service. And the additional savings that we have, as Director Whitley mentioned earlier, the increased federal Medicaid assistance percentage, the FMAP, for our home and community-based waiver program, we see quite a significant savings with that increased FMAP. So to the tune of $3.8 million has been able to help offset our cuts. Additionally, we will be freezing 138 positions across all of our service delivery systems, and then doing some elimination of travel and training, as well as deferred maintenance and operating expenses. And I'd be happy to answer any questions you may have.
Thank you. I will open it up for questions. Assemblywoman Howard.
Thank you, Chairman Frierson. My question's regarding maintaining the flat caseloads, specifically for COPE, PASS, and SLA. You know, I can't imagine how long some of these families have been waiting on the wait list, and now we're just going to cap them. But my concern is with the likelihood of violating the Olmstead decision and the Americans with Disabilities Act by capping the program caseloads. Can you speak about the consequences we're going to face by doing that?
Tina Schmidt for the record. While sometimes budget cuts can be seen as a violation of the ADA and the Olmstead Act, really what becomes significant is if those cuts start to create the risk of segregation or institutionalization. So one of the areas that we really as a state agency are obligated to focus on is prioritizing the services to ensure that we are not seeing unnecessary institutionalizations. So we have the opportunity we do currently work with community providers. Some of those have been able to obtain CARES Act funding to provide COVID-specific services to seniors and keep them out of institutions. So we will continue to utilize that as a method, as well as working with those community providers to ensure that people are not becoming institutionalized unnecessarily.
Thank you for the follow-up. By any chance, do you know how much CARES Act dollars they received?
So my agency, under a portion of the CARES Act, which was the Older Americans carve out under the CARES Act, we received $7.1 million. We have been funding that. We created an emergency funding stream. We do weekly opportunities for community partners, and we have about 4.3 million left of those funds at this time.
Assemblywoman Miller.
Thank you, Chair. My question is referring to the Autism Treatment Assistant Program. If you could briefly explain, for the individuals receiving these services, is this for anyone that is identified on the spectrum, or is this just for individuals with more severe needs, such as maybe nonverbal or aggressive behavior? Also, if you could give a brief snapshot of what the age is, if there's a limit, or does this serve people through their adulthood? And also, how many of the individuals who are receiving these services are also dual enrolled in our schools? Because again, when students are receiving these additional necessary services outside of school, it is imperative because it helps them with their success. So I know that was a mouthful of questions, but those are my questions.
Absolutely. Dina Schmidt for the record. So let me start with just a brief explanation of our Autism Treatment Assistance Program that is operated through Aging and Disability Services is separate than the Medicaid Autism Treatment Assistance Services. So our program serves those children who are not Medicaid eligible. We do provide some case management to Medicaid eligible children, but we don't provide the actual services, the ABA services. Those are provided and paid for through the Medicaid program. So the children we serve are either underinsured or they have private insurance that may have a maximum. And so we have several programs. One of our programs within the autism treatment, we can supplement their health insurance program if it doesn't cover or they hit their maximum. We provide that. If they can't afford their copays and deductibles, we can help them offset those costs. So we have a variety of services within and programs within the Autism Treatment Assistance Program. Our program does serve children up to the age of 18. And I don't have the number of children dually enrolled in the school system. I think that's been a request in the past, and I'm not sure if we have that, but I will do my best to find that information and do a follow-up with you. And did I miss anything else?
No, that actually answered my questions. Thank you.
Assemblywoman Titus.
Thank you, Mr. Chair, and thank you for that. Again, tough decisions. Can we expand a little bit on the FMAP? I know that you mentioned it was going to be a $3.8 million increase in the FMAP, but what I'm hearing is that the federal government has actually provided a 6.2 enhanced FMAP rate to the state during the pandemic, and in Nevada, that for those who don't know what that means, the medical costs are being paid 71% by the feds and 29% by the state during the calendar year 2020. But we budgeted in the 2019 legislature 65 by the feds and 35 by the state. We also know, and we've brought up several times, that the whole utilization of the Medicaid services is significantly lower due to the limited access to the providers during that. And we've asked in the past, was there any savings? And we've been told that perhaps there's no savings because we actually have a managed care organizations that support our Medicaid patients, and that though it's a set rate on that, but in reality, we do have something called the medical loss rate, so that if those companies make a certain profit, that comes back to the state. What I'm understanding that there's may be a huge savings in the general fund. Some have actually said that perhaps as much as $30 million a quarter. So I'm wondering if this was factored in the overall COVID fiscal plan prepared by your department, Medicaid and DPHS, because I heard that yesterday DHS actually testified in the Senate yesterday that if this trend continues and that the 6.2% FMAP is available through the end of the year, you will not need to make any cuts to Medicaid. So would you clarify that, please?
For the record, Richard Whitley. We'll definitely dive deeper into that in the Medicaid presentation, but sequentially, you're right. The FMAP is brought up here in the Aging and Disability Services because it does impact their budget. But you accurately identified the sort of the three legs of the stool that I think are the cost factors for Medicaid, which are the FMAP, that federal percentage that we get that then requires the state general fund match, the utilization, how many services are used, and then the caseload, how many people are enrolled. Those three variables make up the overall expenditures for Medicaid. What we do know and can calculate is that enhanced FMAP, that enhanced federal medical assistance percentage. We know what that is. That's set to expire at the end of September. There has been indication by the U.S. Department of Health and Human Services that they will extend the emergency, the public health emergency, which would allow, not through Congress, but through the U.S. Department of Health and Human Services Secretary, the ability to declare that and issue the continuation for another 90 days, the enhanced FMAP. So the deadline for that is July 25th. And it's one of the reasons that in the governor's proclamation, he asked for flexibility, because if we have that extension, perhaps we don't have to do some of these cuts and reductions. What we don't have are the other two variables with enough data to be able to make sound projections above what was projected, which seems low given the impact of unemployment. But I think the thing to be aware of is we're not going to see probably a rapid enrollment in much the way that people are seeking unemployment insurance. People that were working that maybe didn't have underlying health care issues perhaps aren't going to enroll until something emerges. So there have been some national reports out sort of cautioning states to to not rest on what their increased caseload was in the first few months, because it may be gradual and over time. So again, don't have a lot of data to be confident on that projection, but it is an influencer on cost. Utilization, we do know for the last couple months that a lot of healthcare really was not being provided. You mentioned and so fee for service, we do have those dollars, which give us an indication of managed care. We will go back and we will recover because their managed care is given a capitated rate, which we've paid. We will go back and recover those dollars that were essentially overpaid. And in no way am I indicating like they did something wrong. That's the payment schedule that was approved. But we will true that up, and that will yield a savings to the state. But I can't say what that dollar amount is, and we can't balance a budget. I mean, I tried to tell you the truth. I did try to say, like, we're going to get this back. Can't we just leave this? And so that's why you see before you today these reductions that are very harsh. It's to achieve that cut, but coupled with flexibility and the ability to actually, this is a changing environment week to week, as most of you know, in terms of the flexibility of the federal government, what resources are made available. And so my fear is if we turn services off, we have a fragile healthcare system as it is. We've been working on enhancing it, but if we turn things off, we may decimate a whole service line. And so from an agency perspective, it culminates in my ask of having flexibility to continue to look at what this, if the Emergency Act gets extended and the enhanced FMAP occurs, the utilization, if it continues to be lower than projected, and then the caseload. If those variables suggest a savings, then we in fact may not have to do these cuts in Medicaid and reductions.
Follow up, Mr. Chair? So, and thank you for that, because that's really important information. And when do you think you might have some better numbers for us to give us? You said you just saw some numbers a couple of days ago, and so how soon, and again, this is tough because providers don't always put the billing in, but there is a limited time on when they can bill. So how soon do you expect to have some better numbers for us?
I think we would like to have a couple months in terms of utilization, but it really, I think the FMAP is the key. You know, like I said, the timeline for that is not, maybe May, June is not really enough to project forward on utilization, especially if healthcare opens back up and the utilization occurs. I can't say. I can't say.
So thank you on that. You mentioned June numbers just came in, but the crisis started in March. And so you're saying you just got the numbers for March, April, May, or what in June, what numbers did you get? June numbers or March, April, May numbers?
No, we have March, for the record, Richard Whitley, we have the numbers for March, April, May. But again, we're starting to see an uptick in utilization as some primary care has opened back up. And so that's where the hesitation is. We have those numbers and I'm happy to make those available for fee for service. So the delay will be going back to managed care and then truing up to what their expenditures were. But we do have fee for service as current as June.
But on the FMAP and everything else, but I can always wait till we get to that one a little bit later. I'd like to go back and focus under the services for children, the autism treatment program. Our other colleague had brought up. Mr. Whitley and I have been around long enough that we remember when there was almost no treatment for children with autism. And we had a lot of discussions about how to make sure that those kids did get treatment. And Mr. Whitley may remember the numbers more, but when you think about causing delays in services that will lead to regression in areas of language, motor, and social skills, those will affect our schools also. Years ago, there were numbers about that and what it actually would cost if we didn't treat children. I don't remember those numbers. They're probably buried in a file somewhere. Mr. Whitley or one of his staff may remember it, but I just want to emphasize to this body that the long-term cost is much, much more than the 5.7 million that we're talking about today in the devastating effects that happen to the families that have a hard time getting treatment for their children. So I just wanted to make sure that was on the record. And Mr. Whitley, do you remember those discussions and what that number might have been?
For the record, Richard Willie, I don't have what the cost of delayed service is off the top of my head. We will provide that because it is truly an early intervention program that does prevent more costly and personally devastating health outcomes by intervening early. And I would say the legislature, when the decision was made to invest these general dollars, aside from Medicaid clients are families where the child has autism will continue to get services. These dollars help probably that population of underemployed or employed individuals whose health plans have their commercial plan has a deductible that's too high to meet, or limitations that becomes the barrier. So we really had achieved, I think, a universal approach to autism that had a consistent system for all people in our state. And I think that's the devastation that will occur here is in very few programs do we have this standard established that benefits all children, regardless of their income or their payer source.
And thank you, Mr. Whitley. And Mr. Chairman, you know, there's very few things in your career where you get to do something that really makes a difference in the state. The work that we've done in autism over the last decade, thanking Senator Orenshaw for all of his work, has really made a difference to the families in this state. If I may ask about the services for seniors, this basically helps maintain their independence so they don't end up in a nursing home. And right now, nursing homes aren't one of the safest places to be. They have their own set of challenges. So if you could elaborate a little bit on some of the funding changes there and what might possibly, I believe there's a proposed cap to the individuals that would be served, but we currently do have a wait list. So if you could elaborate on that right now so that we'd have a better understanding of it.
Dina Schmidt for the record. So our personal assistance program, this is a 100% state general funded program that does provide in-home services to seniors. There is also other personal assistance program. The Medicaid program also covers personal assistance care. So families and individuals that need these services, multiple opportunities. Our program really is kind of a wraparound. We often provide services while we're helping people get enrolled in the Medicaid waiver. And so we use our services short term to make sure that there's in-home supports immediately while we're getting them over to another pay source, such as the Medicaid waiver. Additionally, our care coordinators, if they're not eligible for Medicaid, work on other community opportunities. We partner, like I mentioned earlier, with community programs to provide some of these services. And whenever possible, if we have CARES funds that would meet the need, if an individual was needing home services based on COVID and it was appropriate, we could provide the services through those funding streams. And again, yes, so we do have a wait list of 23 at this time. And so those individuals we would prioritize, you know, we touch base with them on a regular basis to make sure their needs are being met either through family or community supports. And if they are at risk of institutionalization, they become our top priority by all means.
And Mr. Chairman, if I could just quick follow-up. So with the current wait list, with the change, will there actually be a cap in services? I'm not sure if that was definite or not. And have you taken a look at what the wait list might turn into?
So right now the proposed cap is 118. So we have some room to fill the people that are waiting as soon as we can find providers. So we are hopeful that we'll get the folks on the wait list off once that cap, but we are intending to cap it at 118.
I'm sorry, Mr. Chairman, cap it at 108?
I'm sorry, let me just verify. 118.
118. And currently the caseload is 96, so that does give you room to try to keep the wait list down.
Correct. Let me just, for the record, Dina Schmidt, for the record, let me make sure I'm clarifying, because we have the two programs, right? The personal assistance and the COPE, and I want to make sure we're not mixing numbers.
Okay.
So for the personal assistance program, which supports individuals with physical disabilities, the cap will be at 118. Our current caseload is 103, and we have 23 on the wait list. For the COPE program, which specifically serves seniors, the cap is at 95. We have 28 on the wait list, and our current caseload is at 95, so we are at that cap. So as individuals come off, we would add another individual on.
Thank you very much for clarifying.
Assemblywoman Carlton, you want to wait until the next section to give it the FMAP-related questions? I'll go on to Assemblyman Kramer.
Thank you, Mr. Chairman. Dr. Whitley, I want to ask a question about the supported living arrangements. My understanding, this is for basically developmentally disabled people so they can more or less live on their own with some assistance. And some of these disabilities are slight and some more severe. Yet my understanding is that this program, it gives the same amount per person regardless of whether it's severe or slight. So my question is twofold here. Is this reduction, the 3.9 is the combination of the JDT and the SLA reduction. How much of that is for the SLA people? How many people are being served? How much their help is being reduced? And is there any discussion about making that help for SLA more for those that are severely developmentally disabled and perhaps less for those who are only marginally disabled? Thank you.
Dina Schmidt, for the record. So while we, in an exercise when you are required to come up with a 14% cut, you have to come up with a dollar figure. It does become very difficult to nail down a number for each program when you're dealing with human lives. As you mentioned, many of the folks that we serve in our SLA and JDT programs have variations in disabilities, some requiring intensive care, some requiring very little supports. And that can change from month to month. So what our goal is, and we've had to do this in the past when we've had budget reductions, is really we look at the budget cap we put in place and we make adjustments accordingly. So if an individual comes to us and has extreme needs and we have to increase their services, we look at other areas where we can reduce services. So it's not a straight number because we're dealing with human lives and very complex human lives. And so our goal is to really make sure that we're meeting the needs, and where folks have other natural supports, we try to transition them there if we could, to reduce the state burden and to ensure that services are provided to all the people that need it. So I hate to not be able to answer it with a definitive number, but as you mentioned, we are dealing with lives that are very complex and changing day to day. So our goal is to meet our budget cap that we put forward. We put numbers forward on all the SLA and JDT services, but we will have to move those as the need changes. Right now, many of our JDT sites are not open, so we're seeing an underutilization, which we can shift those services over to SLA if we're seeing a higher need in our SLA supports. Once JDTs start to reopen, we may have to shift some of that back. So it's a daily process to monitor this budget, but our goal is to stay within the cap that we've given ourselves to meet those reductions that were necessary.
Follow up, Mr. Chair. So again, the question is, has there been given any thought to having a higher stipend for those developmentally disabled that are severe versus the ones that aren't when you're talking about the supported living arrangements? Thank you.
Dina Schmidt, for the record, I apologize for not answering that portion of the question. So we are working with the Medicaid division right now. Our rates for those supported living arrangement services are established through the Medicaid program. And we are currently in the process of a rate study and have asked for a tiered rate, just as you mentioned, that we would have to try to get approved, and we would have to have that approved through CMS. And we intend to probably bring that forward in the next biennium once we have that study done. But we agree. We feel like there really does need to be a tiered rate. Right now, there is a set rate that's approved, and we can only pay that rate. So yes, it is our goal to get there.
Thank you. Assemblywoman Douglas Boone.
Thank you, Speaker Frierson. My question is, you stated earlier that you don't receive money, and this is referencing the autism treatment assistance, that you don't receive money from Medicaid and that you work with families who have insurance. But my question is actually two questions. The first one is, how do you support families who, with the COVID-19 pandemic, have been laid off and don't have access to insurance? How are you still able to support them? That's question number one. And then question number two, you stated that you had a waiting list. What happens if a young person actually ages out while they're on the waiting list? What services do you provide for the families? Thank you.
Dina Schmidt, for the record. So in the autism treatment assistance program, our case managers support the families with whatever those needs might be. We connect them to other services that they may be needing. We connect them to social supports, school supports, and we try to help educate the family. Part of our job is to educate the family on what services are available to them and how to access those services. So in your question regarding a child aging out, we would ensure that they were aware of any benefits that child may be eligible for once they've turned 18 and help them through those processes, whether it was a Medicaid application, a college support program, or a funding stream that they may not know if they wanted to continue their education. We would help them with that. And during COVID, that's a really great question, and I appreciate it, because I have to say that our autism treatment assistance team has been very creative in finding ways to support families, especially virtually, and ensuring we've seen some amazing outcomes in the program where our people have been able to work directly with the families who, in a previous environment, the mom might have taken an opportunity for this to be a break, and now they're helping educate the mom on how to work directly with their child or the parents in the family environment, and helping change that dynamic so that they can, because we know that isolation for many kids with autism has been very difficult and has created a whole new set of challenges for these families. We were not able to originally provide telehealth, but we've gotten recent guidance from Medicaid program, and so we are now able to provide telehealth services so that these families can continue to receive those supports. And then I just did want to add, earlier somebody had asked about the age, and I apologize, my staff have corrected me, I misspoke. We actually serve children through the age of 20. So just wanted to get that on the record.
Thank you. I'll go to Assemblywoman Peters.
Thank you, Chair. And thank you, Director Whitley, and your staff for putting in all the hard work to come up with this budget. I do have a question regarding any potential impact to maintenance effort requirements that may exist for some of your federally funded programs, and if you are able to avoid some of those cuts that may result in us having to repay federal funds.
Dina Schmidt, for the record. So the only program within Aging and Disability Services that does have a maintenance of effort is our early intervention services program, and there are no proposed cuts in those programs at this time.
If I may, one other issue that I just want to make a statement on, mostly because I understand and appreciate why we've had to cut some of these, but our family preservation program is so important to those families who have children with very severe disabilities, and those costs of care for those children. I know personally a number who are waiting for medical care beyond what they can afford, and what's this, under $20 cut a month, that only gets us $250,000 in savings, can really impact a family who's fighting to put food on their table. So I would just consider like what impact that has to our community and the limited folks who this actually impacts.
Tina Schmidt, for the record, I wasn't clear if that was a question, but I would just highlight the Family Preservation Program serves families up to 300% of poverty. And at this time, we are serving 648 with no wait list. So at this moment, there won't be an impact to any particular families other than the reduced monthly amount, which, yes, that is a challenge for many of them who do have high needs.
Thank you. I'll go back to Assemblywoman Benita Thompson.
Thank you, Chair. I just wanted to kind of put together thoughts specific to aging services for our seniors. So, because I think it's probably going to end up being more of a call to action for the bigger system, or at least the community, for how we're going to make sure that we are taking care of our fragile seniors, because we know with the COPE program for the elderly taking a hit, for those who are elderly using the personal assistant services, and then capping the programs, it just makes sense to me that we might want to think about at least a safe place where our vulnerable seniors can land. And I actually am of the thought that I don't necessarily worry so much about the Olmsted decision, because I don't think that these folks are going to end up in institutions. We know that the industry of skilled nursing has moved away from wanting to take any long-term Medicaid patients, and to find those beds are very hard. So this idea that people, our seniors will just default to going to living in a nursing home it's just not going to happen, right? They just won't have a place to go that's safe. They just won't be at home that's safe. But the catch for that has become those group homes for seniors through the Home and Community-Based Service Program, so that you at least can get someone into the queue and then try to keep them safe at home, try to keep them from falling or turning on the stove until you can get them into a group home while they're safe. And so I would really say that we shouldn't make the assumption that these programs are deferring people out of nursing homes. I just don't think that those services are there. And so for me, the catch for them is if we could maintain something in place to, like home and community-based services, that would be safe. I know that we're holding a number of positions. I was so excited last session when we could grant a good number of positions here, because we recognize we have to grow this area, since we just can't defer anymore to the skilled nursing industry to care for seniors in that way. And ultimately, seniors would rather be in more of a group home setting than in an institutional setting. But if there's a way that we could at least hold that piece strong, that makes sense, because we have a place for that community to ultimately land.
Tina Schmidt, for the record. So yes, while we are holding positions frozen in the Home and Community-Based Waiver Program, the Medicaid program has not proposed any cuts to those waiver slots. So the impact will be on the state staff to be able to ensure adequate service and timely service with higher caseloads.
Other questions? In this section, I know there's some members that have some questions, I think, in some subsequent parts of the presentation. So if there are none, I'm going to move on to, I guess, Child and Family Services.
I can do that. This is Richard Whitley. The next presentation in our handout is Medicaid. It's healthcare finance and policy. But if
I'm
you
sorry.
would like me
I'm
to
sorry. Go ahead and go in your order.
Okay. Thank you.
Good morning, Suzanne Bierman, Administrator of the Division of Healthcare Financing and Policy for the record. Thank you for the opportunity to speak with you all this morning about the Medicaid program and our proposals. Some of my introductory comments might be a little bit duplicative of the comments that Director Whitley made previously, but if you'll indulge me, I would like to go back over some of those key points that are providing a little bit of volatility and unpredictability in the Medicaid program. So just to begin, the Medicaid program in Nevada, the division administers both the Medicaid and the CHIP programs, which provide health insurance coverage to now over 700,000 low-income Nevadans. This is health insurance coverage which pays for things like doctor's visits, prescriptions, coverage for kids and families and individuals with disabilities. The program is also jointly financed and administered by both the state and the federal government. And recent legislation passed at the federal level in response to the COVID-19 pandemic has made some changes to the Medicaid program. Most notably, as has been mentioned previously, there has been a 6.2% enhanced rate of the federal matching federal medical assistance percentage, or FMAP, the federal share that's paid for the Medicaid program. Because of that additional FMAP, one of the reasons is that one of the requirements of that additional federal funding is that the state not make any changes to eligibility. So in our proposal here today, we have not made any changes in terms of eligibility criteria. There are optional eligibility categories, and the division does not propose to change any eligibility categories. And again, that is a requirement of this enhanced federal funding. So wanted to highlight that. You won't see eligibility changes in our proposal today. As was also mentioned previously, we have started getting data in that shows some of the impact of COVID, and we do have a claims lag in Medicaid. So early on in the COVID pandemic, it was a little bit hard for us with certainty to really describe what we were seeing, but do now have more firm data and actual expenditures for the month of June, which have shown significant decreases in utilization due to COVID, and that has resulted in significant savings. An additional factor that's at play was mentioned previously, and we're very hopeful and believe that the federal government will be extending the additional FMAP, the 6.2%, under the Families First Coronavirus Response Act and the National Emergency Declaration. And we believe that that announcement will come before the current public health emergency terminates, which is for currently scheduled for July 25th. So again, we have all indications from the Federal Department of Health and Human Services that they do intend to extend this and are just waiting for that official announcement, which is quite significant. I think it was mentioned previously in Director Whitley's answer to Assemblywoman Titus that is estimated to bring in an extra $30 million per quarter to the Medicaid program. So assuming that FMAP does continue and the utilization trends that we're seeing now continue, we do believe that some of these proposed reductions that we're about to go over may be avoided. Again, back to the kind of three-legged stool and the factors that are creating volatility, and I know Director Whitley did touch on this, but did want to highlight again factors that impact our program and also include caseload changes, and we have seen a 9% increase in our caseload since February 2020, and would reiterate Director Whitley's point about at the national level, there being plenty of evidence to suggest that we will continue to see those increases in caseload. So that's something that we are watching and monitoring very closely. So unless these projections change dramatically from the current trend, we do anticipate that we'll have adequate funding to delay these proposed cuts through the end of September and should have additional information on the extension of the FMAP soon, with the current public health emergency set to expire by July 25th. So thank you for indulging those introductory comments. And on the next 3 slides, I will review the division's proposed reductions if additional federal funding does not remain available. So due to the joint federal state administration of the Medicaid program, and because Medicaid is an entitlement program, we are rather limited in our options for making reductions to the program. And our available options include provider rate reductions, changes to managed care program, and the possible elimination of optional Medicaid services, and would also reiterate Director Whitley's comments earlier about the essential nature of many of these optional services. So on this slide, I will review the division's proposed rate reductions. So first, we propose a 6% across the board rate reduction for a projected state general fund savings of $53 million through the end of state fiscal year 2021. Beyond that, we are making changes to several rates. We have a proposed rate change for habilitation services, and we also have proposed the deferral of several rate increases that were passed during the 2019 legislative session, specifically raises that were, or rate increases that were passed for acute hospitals, neonatal intensive care services, pediatric intensive care services, and personal care services. As was also mentioned earlier, we're seeing decreases in utilization on the fee-for-service side. We expect the same is the case in the managed care program, and are working with our managed care vendors to recalculate and recertify those capitation payments. I will say one caveat when it comes to our managed care program is that those savings do take some time to materialize. We have to get our renewed rate certified and approved by CMS. So that's something that we're working on, but does take some time before those savings materialize. So for that reason, we've also proposed here to postpone some of our managed care risk mitigation payments, and delaying those will provide additional flexibility and savings in the current budget. So next, I would like to go over some of our proposed limitations in services. Moving on to our optional services and the service proposal here. If the extension or enhanced FMAP is not continued, this slide shows services that are proposed to be limited or reduced. And those here include the elimination of adult dental. Currently, Medicaid pays for prosthetics and dentures for adults. Services for children would remain covered under the EPSDT, the early and periodic screening, diagnostic, and treatment benefit, as well as dental services for pregnant women. We are proposing a limit to physical therapy for adults and limiting that to 12 sessions, and also a change to our hospice program that doesn't allow personal care services to be accessed at the same time as hospice. The next slide contains the full list of optional services that we've proposed for elimination in the event that additional FMAP is not available. So here, this slide shows the list, and again, I would just note that many of these are very critical services, but under our options that are available to us from CMS, this is one of the places that we are able to find savings to meet that 14% budget target. And I would note, importantly, that this proposed elimination of optional services applies to adults only. So with that, I know that was a lot of information. Pause, and happy to try to address any questions.
Thank you, Assemblywoman Carlton.
Thank you, Mr. Speaker. So with that, let's go ahead and go back to the provider rate reductions, the beginning of your conversation. That's 6%. And if I have my notes correct, it's approximately $211.6 million, which is $53 million in general fund, and the state would be losing $158.6 million in other funding. So 53 million versus 158 million. And is that a pretty close ballpark figure?
Thank you for the question, Assemblywoman Carlton. Suzanne Bierman for the record. Yes, that is correct. And I think that that is something important to keep in mind as we talk about all of the Medicaid reductions. Certainly there's savings here to the state budget, but also a lot of federal funding that becomes unavailable and, larger amounts that are then not available in the state.
And thank you very much, Ms. Bierman. And Mr. Chairman, if I may, I'm just going to go through a couple of others real briefly. I'm not going to ask the department to comment on each one of those. I think we're all able to read and understand what these programs are about, but I believe it's really important for the record that we state out loud that when we talk about a 2.5% reduction for acute care hospital rates that we approved last session in Senate Bill 528, we're talking about a savings of $20 million, $5.5 million in general fund, but $14.5 on the other side. So we would be losing $14.5. With the 25% reduction for the neonatal intensive care unit, we're talking about a savings of 14.8, but only 5.2 of that is general fund. 9.6 is from other funds. On a 15% reduction for pediatric intensive care units, the PICU rates, which we discussed very thoroughly over the last 2 to 3 sessions, we're talking about a savings of 1.5 million, 514,000 in general fund, and then the rest out of other funds. And with a 3.3% reduction for personal care services, we're talking about a savings of $3.6 million, 1.2 in general fund, and $2.3 million from other funds. There's a number of these that I could go through. We're going to go ahead and start totaling them up, but I think the gist of this, and I think I've probably made my point, is that we are going to be losing a lot more than we're going to be saving, and at the same time, we're going to be harming our constituents and Nevadans who need these services. So I just wanted to make sure that we had that statement on the record, Mr. Chairman.
Thank you, Assemblywoman. Assemblyman Carrillo?
Thank you, Chair. Thank you for recognizing me. Sorry about that. Didn't mean to scream into it. I got skipped over on the other question that I had proposed. I'd sent to an email. Obviously didn't get it. So
I'm sorry. Feel free to ask the question. Directly Whitley is here, but I think your question specifically referenced page 6.
Yes.
So I was waiting until we got to that part of the presentation, but you can relay back. Dr.
Okay,
Willey's,
can I, because really it's more of a data question than anything else. And I don't know if, who this would be, who would be the one to answer this question so they can decide. In March, your wait list for ATAP was 236 individuals with an average wait time of 174 days. If we cap ATAP numbers, will that affect those numbers? And do we have any idea how much longer individuals might have to expect to wait for these services?
Tina Schmidt for the record. So yes, those were the March numbers. As of May, our caseload was at 892 with 191 on the wait list. One of the challenges we've faced during COVID was RBTs, as has been a challenge in this program for many years, is getting enough registered behavioral technicians certified. We were able to reopen that testing process. We were excited to be able to find a safe way to reopen the testing process and continue to enroll those providers. So as soon as providers are available, we are able to provide service. That is one of the reasons that causes delays in service is the lack of providers.
You don't have any timeline that you can refer to other than just a wait?
Tina Schmidt for the record. So I don't have a timeline as far as how many RBTs are coming on board each week and how long it takes people to go through the process. That is part of what causes delays, but the delays will continue if we cap the program.
Okay, thank you. I do have another question, Chair. And this is more of the Medicaid question. It is my understanding that none of these changes that may be approved by Medicaid can happen right away because you will need to hold public workshops and such, correct?
Suzanne Bierman for the record. Yes, that's correct. We will have to hold public workshops, and we have to do that 30 days before we then submit our state plan amendment to CMS, the Centers for Medicare and Medicaid Services, our federal partner, for review and approval of our proposed changes.
Part two of that question, it has also been brought to my attention that several changes have already been made without public comment with an effective date of July 1st. Can you explain to me why these changes do not need public comment?
Sam Bierman for the record. I'm not aware of any of those changes. Can I check with our deputy administrator? No, we would need more additional information. We're not aware of making any state plan changes without going through the public comment process. But happy to work with you offline to find out additional information.
All right, thank you. And because of at least some of those changes were primarily targeted at behavioral health transportation, is that not a violation of Mental Health Parity Act?
This is Richard Whitley, Director for Health and Human Services. Without having something more specific, we certainly do adhere to the Mental Health Parity Act, and I would, if you have somebody providing you information, I would take it as a complaint and investigate it. But we have made no systemic changes to the Medicaid program that would lead to that violation.
The only reason I say that is because there was a letter that was actually sent out to Medicaid members, so that's why I was just putting that question on the record.
Dwayne Young, Deputy Administrator for the Division for the record. Assemblyman Carrillo, I believe that you're referring to the changes within our non-emergency transportation policy, in which there will not be, our vendor will not be handling the L2Ks going forward, and that's because of legislation that happened last session, AB 66, which allowed for secure behavioral health transportation, and recipients were notified of that. We will be having an actual public hearing in July to align the changes in the contract with the chapter, but those changes do reflect the ability of the division to solely enroll providers who provide secure behavioral health transplant and not the non-emergency transportation vendor providing those services.
Assemblywoman Tolles.
Thank you, Mr. Chair, and thank you, Director Whitley, and everyone who has provided this information to us. I certainly think I speak for all of us that we hope that that extension of FMAP does carry us through to December 31st. And so in that regard, if that is the case, you indicated that there's going to be possibly no cuts or at least less cuts. And so I just wanted to know, if we do get that extension of FMAP, do we have an estimate of whether or not that means less cuts and to what extent? That's my first question. I've got two follow-up. Thanks.
Hi, Assemblywoman Tolles. Thank you for the question. Suzanne Bierman for the record. That enhanced FMAP will allow us to propose delay making any changes through the end of the year.
That is fantastic news. So if we see other additional savings, so we'll delay the 6% cuts, is that correct? Does that also include, does that, that means we delay the 6% cuts, and then does that also include the elimination of optional services and some of the other things that were mentioned?
For the record, Richard Whitley, it's one variable that would allow us to extend out while we I think in the response to Assemblywoman Titus, I mentioned the two other variables, caseload and utilization. It would allow us to not initiate the public workshops and notify CMS of our intent to eliminate or reduce, so that we could have a little bit more time to have data from the utilization and the caseload to make that determination if we need to do any cuts at all. So all three of those variables have to be considered as the influencers of what revenue we have would have available. And we have the firm one, the 30 million that was mentioned, is if the enhanced FMAP is extended to December 31st, and then the utilization and caseload. So with just the extended FMAP, we could push out be able to have the other data available to make the decision if we need to commence with these harsh reductions and eliminations. Again, I know this special session is focused on budgets, and I realize the position we put you in, and it is really just to go back to the flexibility part. It's just we don't have all the information, and I'm telling you in a heartfelt way, we don't want to do harm to people or to the healthcare system, but we don't have all the information to make the decision, the decisions, and they're emerging, and so I just I offer that up.
Thank you so much, and we appreciate that, and we are with you and hoping for the flexibility to put as much back in as possible, so that what we're looking at here is the worst case scenario and not the reality as we get closer to the end of the month. I do think, though, perhaps it might be helpful to get an idea of prioritization of how you would use that flexibility to prioritize reducing cuts and putting money back in. And some of the things that I've heard so far in our discussion, as well as in public comment, is the federal matching. And when we have state savings, though, we're leaving quite a bit of federal matching. So I would hope that would be a priority. Second, areas where there's increased cost and impact down the road, for example, early intervention with autism and knowing the lifelong impacts and the regression that we might be facing. And then finally, things that impede with living and working, like prosthetics or access to optometry that would keep people, and dental care that would keep people from being able to live and work. So could you help us understand perhaps what those prioritization matrix is for you in decision making as you look at that flexibility to put things back into those budgets?
For the record, Richard Willie, I think you really nicely laid out those considerations. I would say the one sort of caveat would be how much funding then is available, because they all come with different costs of general fund. And so I think all those variables together, population-based, really looking at a public health approach, that if like an early investment could save money later if we intervened early, definitely. If we could help people to live independently and reduce poor health outcomes or tragedy or costs down the road, certainly. I think you laid out nicely those considerations. We could certainly try to put them in an order, but I think the overall then the determinant for that is how much general fund is available to start bringing some of those services off the list for reduction. That really is, I think, in the end, because certainly when you look at them, some are more costly than others.
Thank you for that. I appreciate that response. And if I could ask just one last question. As you know, skilled nursing facilities are something that have been a great concern as I've had 25 COVID-related deaths in a skilled nursing facility in my district, just 2 miles from my house. We've had plenty of conversations about that. They certainly serve our most vulnerable. And if we do, as we are looking at these cuts, if you could just help me clarify a little bit, with skilled nursing facilities, it's my understanding that they gain their funding through 3 different mechanisms: per diem, behavioral health add-on rate, and then the ventilator rate adjustment. Are the proposed cuts being applied to only per diem or to all 3 of those pools of funding? Thank you.
Dan Bierman, for the record, they are proposed to apply to all 3.
I'm sorry, Assemblywoman, were you satisfied? Okay. I'm going to go to Assemblywoman Swank, and then, just so you know, Assemblywoman Spiegel next.
Thank you, Mr. Speaker. This is a question for Ms. Bierman. I just have thinking about the unemployment benefits that have increased, the extra $600 a week that folks have been getting have been moved onto unemployment. We know that's kind of edged some folks outside of Medicaid eligibility. Now that program is supposed to end July 31st, and so we would be anticipating that some of those individuals would move back onto Medicaid after that program end. And even if it's extended beyond July 31st, at some point it will end. So if you can talk a little bit about the preparations you have for that increased demand on Medicaid. Thank you.
Thank you for the question, Assemblywoman Swank. I think that is one of a number of factors that we think may contribute to increases and continuing increases in our caseload. We know unemployment changes happen. We know that people have employer-sponsored insurance coverage that runs out after a certain period of time. We know that people prioritize things like unemployment insurance and food security issues sometimes over going to a physician, especially in times of a global health pandemic when there are other security and social distancing issues at play that may lead to a delay in the amount of time that it takes for us to see some of these increases in our caseload. But we do know that we continue to expect to see our caseload continue to rise throughout the economic recession.
And thank you. So do we have an idea of if this program ends July 31st, what that increase will look like?
Thank you for the question, Assemblywoman Swank. I did get some additional information from the Division of Welfare and Supportive Services that the $600 is actually exempt from the calculation for Medicaid income eligibility.
Thank you.
Assemblywoman Spiegel.
Thank you, Mr. Chairman, and thank you, Director Whitley and Administrator Bierman, for the approach that you're taking to this. It's very challenging, and I appreciate all that you're doing in making these very, very difficult decisions. That said, I did have some questions related to access to care. As I sit back and I listen to what we're talking about, I understand that many times, especially when we're talking about Medicaid patients, we have providers who don't want to be providing services because of the reimbursements. And I know there have been a number of studies, and so for example, the Kaiser Family Foundation had done a study where they said that overall physician payments had a pretty good ratio of payment for Medicaid relative to Medicare, but then the Medicaid and CHIP Payment and Access Commission said that when we're talking about things like hospitals, we're actually 5th worst in the country. Now, I know that because of the nature of the pandemic, every state is going through what we're going through right now. Every state is looking at cutbacks. Every state is slashing budgets. But I'm wondering if you've spoken to folks in other states and taken a look at what the impacts could be on our provider network and people having access to care.
Thank you for the question. I have spoken with our National Association of Medicaid Directors to try to stay up to date on how states are dealing with the public health pandemic and the accompanying economic recession. And I do know quite a few states are in a similar position. I believe California and Ohio have recently had to implement reductions to their Medicaid programs. I do know there are other states that haven't yet had to make any cuts to their Medicaid program. One specific example in Arkansas, I know, had a special session a month or so ago and actually didn't make any cuts or changes to their state's Medicaid program. I think it really is a complicated question that has a lot to do with, the underlying nature of a state's tax base. And certainly some states are having to implement those changes, and there are others that have been able to delay. But what I understand from the National Association of Medicaid Directors is currently most states are trying to take an approach similar to the one that Director Whitley outlined, where we seek as much flexibility, knowing that there are a number of unknown variables, and trying to delay these types of cuts to the Medicaid program as long as possible.
Assemblywoman Cohen.
Thank you, Chair. And if I can have 3 questions. Thank you, Director and Ms. Bierman. So as a follow-up to Assemblywoman Spiegel's question, are there specific providers whose willingness to participate in Medicaid we should be concerned with at this point?
Well, we do have access standards in the Medicaid program. We have to ensure that the rates that we pay allow adequate access to the Medicaid population. So that's one protection that we have, and the federal government ensures that there is appropriate access. I will say that that does vary by state, and Medicaid is not unique in having challenges in some areas of Nevada and some particular workforce, as we all know that Nevada has many workforce professional shortage areas. So, but we do have access standards and federal requirements to make sure that the services that we offer are available to our population at the same rate that they are members of the general public. So that's one thing that I would point to is the federal requirement that there's equal access. That's actually a requirement of the Social Security Act. And CMS does monitor that. And we also have network adequacy requirements as well. So, I mean, I think that there always is a general provider shortage challenge in the state of Nevada.
This is Richard Whitley for the record. I would just add that one point that probably should be highlighted is that we do have safety net providers in our state, federally qualified health centers, critical access hospitals. One thing that did not get cut, that is not being proposed to be cut or reduced, are certified community behavioral health clinics. All of those are not impacted by these reductions, and those truly are our safety net providers. But Medicaid is the largest single payer of healthcare, and then you take certain populations like prenatal care, pregnant women. Medicaid pays for 60% of the births in the state. So there are some specific areas where the reliance on Medicaid is heavier than in other areas, certainly impacting specific populations. But in terms of primary care and the critical access hospitals, these reductions will not impact them.
Okay, thank you for that. Additionally, I want to ask about dental services. What dental services will we still be offering to women and children?
So, Suzanne Bierman for the record. Thank you for your question, Assemblywoman Cohen. For children, the dental coverage that will still be available is pretty robust. It falls under the early periodic screening, diagnostic, and treatment benefit. So dental services for kids must minimally include relief of pain and infections, restoration of teeth, maintenance of dental health, and additionally, the EPSDT benefit requires that all services be provided if they're determined to be medically necessary. So if a condition is diagnosed as part of the screening component of EPSDT and is discovered to need treatment, that coverage will be provided even if it's a service that is not otherwise covered in the state plan amendment. Again, that's a federal requirement of the EPSDT program. For pregnant women, in order to reduce the risk of premature birth due to periodontal disease, pregnant women will be able to access dental prophylaxis, fluoride varnish, certain periodontal and restorative services, such as fillings during pregnancy.
Thank you. Then I also wanted to ask about preventative services, because a lot of the proposed cuts seem to be to preventative services, which I think we've talked about today, that there's going to be long-term effects to these cuts. But I think we're going to see real immediate increases in costs to Medicaid here, much more so than in a lot of the other long-term effects that we're going to see. Because we're going to see these relatively minor issues that turn into major issues, and then we're going to see people in emergency rooms and that type of thing. Is there anything with preventative care that you think that maybe we can, I don't know, if there's one thing that maybe we could pull out and tease out and save, or, you know, like for instance, the 12 physical therapy, the 12 different visits for physical therapy. I mean, I know I met with physical therapy students a couple of years ago who were concerned about not having enough physical therapy. First, you know, they were telling me about patients they had that they were working with that just, you know, and this was before the pandemic, that they were having patients who were ending right back up in the emergency room because they were making progress, they were doing well, and then they had to end physical therapy because they couldn't get enough treatment, and they were going right back into the emergency room. So it's just, we're just seeing these immediate costs that are coming right back to us. So I mean, again, we understand that none of this is good, none of this, no one is happy with this, but is there anything there that you think that we could possibly tease out, or that you could address that we might be able to find some place there? If there's just something you can add to that, or you could give us some more guidance there.
For the record, Richard Whitley, I think as described earlier, the logic of upstream, is it preventive? What would be the cost? What's the population impacted? And what is the cost of that? Otherwise, I can't. Elderly or children. If you have a health condition and you have a need for physical therapy, that's primary to your need. If you have an amputation and you need a prosthetic, that's primary to your need. I think the approach of looking at the services and the impact to the number of people we could provide, and then what those ultimately, it's going to come down to as well, the cost of the general fund cost. And with the limited number of services, again, wrong, not a good use of the word optional, but it is a CMS term, optional services, that it's going to come down to how much funding do we have for us, you know, in terms of even how we put these forward. It's the option, where do we have a margin to make a reduction, and then what does that service cost, and what is that impact? Every single one of these reductions have an impact to the lives of people living in our state.
Thank you, and I appreciate that, and I get that, and we've discussed that today, but these people are just going to end up right back in the emergency room, and we're just going to have a greater cost, and so, but I guess we all understand that, and we appreciate the work that you're doing, and we'll just have to address that. So thank you.
Assemblyman Flores.
Thank you, Chair. And thank you both for your presentation. And I understand that everything you're doing is incredibly difficult. There isn't a single penny that is a quote unquote good cut. It's just your hands are tied. So I first just wanted to say and acknowledge that. So a lot of us don't sit on the money committees. So when we approach very complex conversations, we have a tendency to naturally go to policy questions. And I appreciate you referencing the fact that there's a lot of emerging issues that have not yet been identified, and therefore you need flexibility. So I guess the question that I have is, a lot of us are going to be right back here come February. And, outside of trying to fill these sweeps again, I'm just trying to understand if you could foreshadow what you foresee the policy question and your ask in February, so that some of us can kind of put this conversation in a much broader context, not just what we're doing right now, but the implications of the policy conversations that we're going to have in February, so that we could utilize this interim to kind of start thinking in that maybe more of a holistic approach. I don't know if you've identified policy restrictions, limitations that need to be addressed, so that when we're moving down the road with these massive cuts, to maybe give you some more flexibility to be able to do what you can with what limited resources are being put in your hands. And I know that's a very broad question, but I know for me at least it'd be helpful just so I can think of this outside of just the context of what we're discussing now, but what this means down the road.
For the record, Richard Whitley, thank you so much for that question, because I think it goes to this point I was making earlier, that we have a fragile healthcare system, and we've incrementally, since the expansion of Medicaid, have tried and worked with the legislature, with the executive branch. This last session, I feel like we've had our greatest gains. We've tried to incrementally make our healthcare system less fragile and serve all Nevadans. I think that this crisis that we're experiencing is evidence of that we don't have a diverse payers investment of payer sources to the healthcare system. We're certainly happy to provide for policy consideration how other states fund their Medicaid program with provider fees and taxes. We took a stab at this 2 sessions ago with an optional provider fee. We've had no provider group take advantage of it, to be able to even increase their own rates by providing a fee that could then be held up and matched to Medicaid with CMS and bring in a higher rate. Most other states have a diversified funding mechanism for their state Medicaid program, and we don't have that here. We have a fee that health plans pay, and we have a fee that skilled nursing homes pay. But I think there's some rich policy in all of that. I think that we're highly impacted because I think we rank number 2 or 3 in having the largest number of private for-profit hospitals. So we don't have the network of county hospitals. Up until a couple of years ago, we had only 2 federally qualified health centers in our state. that has been growing exponentially, which has been terrific as a safety net provider. But investing in and supporting some of those safety net providers are secondarily. But I think primary is how to diversify the funding so that it's more relied upon. I mean, we're serving the most vulnerable people. 138% of poverty or lower are people that are just they may be employed but underemployed. They're the most vulnerable. Disproportionate representation of minority groups who are living in poverty served by this program. Taking full advantage of the expansion of Medicaid, I believe, was a huge step, and I think the next is to like make less fragile the actual delivery of the healthcare with a more robust system that can rely on more diverse funding. That's from where I sit and how I see it. That would be of benefit.
And thank you for that. It's just important for us in this body to realize that we're in such a difficult situation now. We've made such a huge ask of you, but then we again put the finger back on ourselves to realize what work we have to do in the interim, and then come next session, we just have to have very difficult conversations, but very important policy questions too. So I thank you.
Thank you. And for the body's edification, it looks like we have 3 members with questions in the queue. My intention or thought would be to get through those 3, and then, or now all of a sudden there's 5. I wasn't going to cut you off. People need to eat. So at some point, my intention would be to take a 30-minute break on the floor to have lunch. We have another presentation after this, but we certainly have DHHS here and waiting, so we don't want to unduly delay them, and then get back to our work. So I'll get through. I just wanted to get it out there, and then we can pick up where we left off once we get to that point. So for those of you that are going to have questions, we'll allow them to be asked if we can accommodate just a little break for folks to eat and get back to work. So with that, I will call next on Assemblywoman Carlton.
Thank you, Mr. Chairman. So, Mr. Whitley and Ms. Bierman, earlier we were in the conversation about the FMAP and caseload. My biggest concerns are we have had a number of hotels basically say that they are not going to open, and the rest of them are working at 25 or 50% as far as employees go, and there are still issues out there. Those folks that are represented by a collective bargaining agreement, we pay our insurance a couple months in advance. But those couple of months are in the rear view window now, and so they will not have insurance, so they will become eligible for Medicaid as more and more hotels cut back and or do not open. Has anyone done any analysis on any of the numbers? If you stop and think about it, Texas, we've had a number of the different stations say they're just going to close for the next couple of years. That's 2,000 to 3,000 people in each one of those hotels, and then cutting staff in half in others. When you look at those numbers, the conversation about, yes, we will be getting more money in FMAP, but we have to remember the state still has to ante up its portion. And I believe those folks would not fall under the new FMAP. I think they would fall under the old, but I'm not sure. If you could elaborate on that, and do we have any idea of what those numbers might look like in the next 6 months?
Mayor Bierman, for the record, thank you for the question, Assemblywoman Carlton. Yes, our Office of Data Analytics does produce projections in terms of caseload, and we could provide that information to the committee. But I would say that I think your point is a good one. And again, back to the earlier point about there being volatility in the program and needing flexibility, we do know based on past recessions that it does take some time for the state Medicaid program to see its largest spike or peak in enrollment after, the time that an economic recession begins. I believe I read somewhere that in 2008, the highest levels of participation in the Medicaid program came fully a year after the economic recession began. And I believe, based on some other national information that I've seen, that in some instances, the unemployment to Medicaid ratio of those who are unemployed and then, apply for and are found eligible for the Medicaid rolls can be as high as 50%. So I do think that, we have to watch caseload very closely, and it's something that we're very aware of and cognizant, and understand that, there's a federal share for increased federal and state share, so both cost as our caseload increases, and something that we do monitor quite closely, and happy to share those projections from the Office of Data Analytics with the committee.
If you could.
This is Richard.
Oh, go ahead, Mr. Whitley.
I just wanted to add, if I may, that I think secondary to the people who were employed and who were perhaps covered with like a culinary health fund, I think the biggest risk from where I sit is that's a healthcare system. That's a clinic that we've had meetings with in terms of like early on, so very responsive to wanting to do testing and to care for their members. I don't think that the fragility of this is just the number of people that will become Medicaid eligible. I think it's also the healthcare system in Las Vegas that is going to be impacted by perhaps having members even become enrolled in Medicaid, but we have healthcare providers and specialists connected to that clinic.
And thank you, Mr. Chairman, and thank you, Mr. Whitley. That clinic is very near and dear to my heart. And there's very few things that I've cried over in this whole thing, but the day they closed that and the folks on my side of town no longer had a clinic to go to was a very, very sad day. But the follow-up question on what actual FMAP rate these folks will be at, will it be the newer rate, I believe, where we're anteing up 10 cents or 15 cents and the feds are putting up the rest, or is it the standard FMAP at the 35 cents?
Suzanne Bierman for the record. Thank you for the question, Assemblywoman Carlton. It really just depends on what their income level is and what eligibility criteria they meet. Medicaid has a number of different eligibility categories, and so it would really depend on things like if, what their income was, how large their family size is, how old they are. A number of variables go into determining which of the Medicaid eligibility categories someone would fall into.
Okay, thank you. I look forward to getting those numbers to see how much state general fund we're going to have to come up with as far as our match goes. Thank you.
Thank you. Assemblywoman Neal.
Thank you, Speaker. So I had two questions. One is more of a capacity question, and the one is very specific. So I was thinking about the 6% reductions in intermediate care and transitional rehab centers. And although the rate reduction is going to begin in August 2020, when you have a stroke patient, right, they actually are in the hospital for a series of months and they move from levels of care. So is there any kind of conversation or strategy around when that rate is reduced and the bill comes to the patient to have to ante up for the additional cost, to maybe talk to those providers about working with the medical lien that will potentially become a part of that patient's life as we work through this? And then my second question was, since we're limiting physical therapy, where it's going to be 12 visits, what do we do within a stroke patient that's on Medicaid, right? Because if you have Medicare, you're good. But if you have Medicaid, typically a stroke patient will need more than 12 visits. You might have, just in your intermediate care facility, 3 visits a week. So that's 3 weeks where you've already met 9 visits and then 4 weeks at 12. And so it doesn't even deal with the acute rehab where you need to go to be fully functional. So I just want to know, like, you know, I know Director Whitley, you're extremely creative. Like, where are we at in regards to those conversations and how we have to talk to those patients and those families who may be dealing with this come August, September, October?
So I think what I hear are two distinct questions in what you offered, and the first one being Medicaid recipients don't pay out of pocket, so they would not receive a bill or have a lien placed on them. So if they are on Medicaid, they would not receive that. Just to clarify that. On the physical therapy and the number of sessions, I'll defer to Suzanne to talk about how many, if the need is greater than the number of sessions.
Thank you for the question, Suzanne Bierman for the record. So again, I think this goes back to the point that we are looking for additional flexibility, but had to meet our 14% reduction target, and physical therapy is among the optional services, and we've placed that 12 visit cap on it. I think in the extent that there's an emergency situation, we always have special provisions for additions or medical necessity requirements. You can get an extension of prior authorization, but that's really handled on a case-by-case basis.
Thanks, Speaker.
All right, Assemblyman Ellison.
Thank you, Mr. Chair. My colleague from District 14 hit about 90% of this, but I do have one thing. I want to go through the budget later on, and we can hit on some items, I'm hoping, later on. But how much of the administrative costs has been reduced, like layoffs, furloughs, and the kind of stuff that you're seeing right now? Because right now we're talking mostly about the program. So could you hit on that, please?
Sure, Suzanne Bierman for the record. So we've been fortunate within the Division of Healthcare and Financing and Policy to not have to lay off any staff. And like all state employees are expecting 1 day a month furloughs for this year.
Could you repeat that again? I didn't hear all that. It's kind of hard through them masks.
My apologies. Suzanne Bierman for the record. And within the Division of Healthcare Financing and Policy, we've been fortunate to not have to lay off any staff. And we also are anticipating 1 day of furlough per month for all of the individuals employed by the division.
Thank you.
Assemblywoman Benitez Thompson.
Thank you, Chair. And so I wanted to ask about the requirements that the federal government is giving us on the 6.2% increase in the match rate. We're still waiting for the actual federal guidance to come out that will tell us, in writing what the requirement is going to be for that. Outlining on rate reductions or service eliminations and what's allowable or not. But can you talk a little bit about the confidence that you have that we are indeed in compliance, and despite not having any formal written guidance from the federal government, that to the best of our knowledge, we will be in compliance once we get more formal guidance?
Thank you for the question, Assemblywoman Benitez Thompson. So yes, I can go through the requirements for the enhanced FMAP. That was provided through the Families First Coronavirus Response Act. So the requirements are actually outlined in Section 6008 of that piece of federal legislation. But primarily, the first requirement is that we maintain eligibility standards. As I mentioned earlier, we are not proposing any changes to eligibility. One, I think keeping people covered is incredibly important, but two, we are very clear that that's a requirement of this enhanced federal funding. The next is that we not charge premiums or cost sharing that exceed what was previously charged. That's really primarily a non-issue in the state's Medicaid program. There's only very limited cost sharing at all or premiums, and certainly none of that has increased. And again, that's very limited to certain programs like Katie Beckett provides health insurance for higher income families. But for the most part, it's the case that Medicaid in Nevada doesn't really charge premiums and cost sharing. The next is that you can't terminate individuals for Medicaid during the emergency declaration period. So again, not doing renewals. Basically, there's continuous eligibility in place and has been since the public health emergency has been declared. So good on that front. I think that the last requirement is the one that you're alluding to, and I think the safest approach is just to go with CMS's current interpretation of the statute. Again, this is all new and evolving and fluid, and there was, not certainty in just by reading the statute, and consulted with the Deputy Attorney Generals on whether or not optional services could be eliminated at the same time that the state collected the enhanced FMAP. It is now clear, at least CMS's current policy, is that you can't both eliminate optional services and continue to of the statute with regard to the ability of states to make changes to optional services was overly restrictive, and they have indicated that they may change their policy, but that any additional guidance or changes related to that point have not been formalized. So I feel like right now the safest approach is to stick with CMS's current interpretation, which is that you can't both eliminate optional services and collect enhanced FMAP. Sorry, that was a long answer. I hope that was helpful.
No, I think that's helpful. I think the thing that I kind of, my eye went to most was on the service eliminations and kind of that back and forth and whether or not we were going to have a better understanding just in terms of compliance. And so another piece I guess we'll wait on.
Okay, I just want to make sure you were done. Assemblywoman Benitez Thompson, I think if we, I think to keep the record clean, if we could come out of committee of the whole and then in the body will recess.
Okay, yes, Mr. Speaker, I move that the committee of the whole now rise and report back to the Assembly.
You've heard the motion. All those in favor, please signify by saying aye. Opposed, nay. Motion carries. Assemblywoman Benitez Thompson.
Thank you, Mr. Speaker. I would move that the Assembly stand in recess until
1:15.
1:10?
1:15.
1:15.
Thank you. You all heard the motion. All those in favor, signify by saying aye. Opposed, nay. Motion carries. We are in recess. Yes, if all the members can stay, they're bringing the lunch out, so we'll be having it out here. And we will need to be prompt at 1:15.
What'd you want?
The Assembly will come back to order, and we will go back to order of business 8. Assemblywoman Benitez-Thompson.
Thank you, Mr. Speaker. I move that the Assembly resolve into a committee of the whole.
You heard the motion. All those in favor, please signify by saying aye. Opposed, nay. Motion carries. The Assembly is resolved into the committee of the whole. We are going to pick up where we left off in the committee of the whole with the remainder of the presentation by Department of Health and Human Services with the assistance of BPS.
And Chair, would you mind me just clarifying for members where we are kind of run of show?
Please.
So committee members, it feels like we've asked our questions on the Director's Office, Aging and Disability, Child and Family Services, Healthcare, Financing and Policy. If I'm reading the room right, where we're going to be in the next two sections are Public and Behavioral Health, and then Welfare and Supportive Services. But did we have other folks that felt like they were still needing to be in other pieces of the presentation? A couple more questions. Oh, yeah. Oh, sorry, you're the chair.
Thank you for that gentle nudge. When we are ready with DHHS, we'll continue line of questioning with the existing budget that was on when we left off, but we need to make sure that we have Director Whitley.
Hi, this is Richard Whitley, Director for Health and Human Services for the record. And the budget that we left off on was the Division of Healthcare Finance and Policy, Nevada Medicaid.
And did we have remaining questions with respect to that aspect of the budget? I saw a hand. No? Oh, we do have some. So we will first go to Assemblywoman Titus.
Thank you, Mr. Chair. And Director Whitley, could we circle back a little bit when you mentioned county facilities and county hospitals? Because I think that is important to how that interacts with our Medicaid and Medicare funds. And you had mentioned that we don't have very many county hospitals. And I think I'd like a little explanation on how that impacts us. But for right now, the way I see it, we have 7 rural county hospitals, and we have 1 urban county hospital, and that remains UMC, are the only county hospitals that we have. That's 8. The rest are for-profit, 37 for-profit, plus we have 30 military or facilities. So I'm just curious, or 30 nonprofit and military facilities available. Can you explain how that affects some of this billing payment process, the county hospitals versus the rural hospitals? Because UMC it may be hugely impacted by this, so I just needed some clarification. Thank you.
For the record, Richard Whitley, what I was referencing was a national study to give context to where Nevada ranked in that. But to your question of what does that mean, the county hospitals have the ability to recover administrative costs as a government agency, and so they they have opportunities that are greater, really, in some ways than a private hospital that may be more highly impacted by Medicaid. So there are some benefits to a government operated hospital or facility that isn't extended to the private sector, which makes them, if you take that out then further, it makes them sometimes, clearly more willing to be the safety net provider in the community. So when you have a community with only for-profit hospitals, or the nearest the proximity to a government or a county hospital or a nonprofit hospital may be further away and present some challenges, and that provides challenges to the health carrier, so the insurer who's negotiating contracts with hospitals. So there's where the impact is, I believe, is the fewer county hospitals, the fewer probably people who really want to take Medicaid clients at the lower rate, unless they have a good payer mix.
Assemblywoman Krasner.
Thank you, Mr. Speaker. Thank you, Mr. Whitley. I have a couple of questions. One was provided to me by a medical center in Reno, Nevada. They said that Nevada has received tens of millions of dollars in federal aid for the state's Medicaid program via the 6.2% FMAP increase. And we know these dollars are not going towards payments for healthcare providers. Why is that?
Suzanne Bierman for the record. So that's the same 6.2% enhanced FMAP that we've been talking about throughout the day today. And we've largely used that funding to support our program to cover the increases in caseload. And should it continue, it does go to providers in the form of not having to make this type of, or at least postponing this sort of rate reduction. So that's how we've been using the 6.2% FMAP to date, is to cover those increased costs that are associated with increased caseload.
Who made that decision that none of that money would go to the healthcare providers?
For the record, Richard Whitley, I mean, the rates are already established. I mean, what it did was it postponed our fiscal crisis. I mean, we were able to actually count that, the fiscal year that just ended, we were able to achieve those reductions with reversions because of that. But as you've heard in this presentation, rates and turning on and turning off services in Medicaid doesn't happen instantly. And so the intent of those dollars were really to support the state. It gives a greater federal portion to the state, reducing the burden on state general fund. It wasn't intended to give rate increases to providers. It was intended to really salvage Medicaid in states, and was offered to all the states as a way of reducing the burden on state general fund. I don't know if that is helpful.
That's fine. My next question is also in regards to the rate reduction, the 6% across the board rate reduction. I'm just wondering, how do you think that this 6% reduction in Medicaid reimbursement rates for healthcare providers will affect access to care? Do you think that some healthcare providers will be forced to just stop accepting Medicaid patients or move out of state?
Suzanne Bierman for the record. So as a part of our state plan amendment process to effectuate these rate reductions, we do have to submit a state plan amendment to CMS, and as part of that, they look at access to care and ensure that we are still able to meet the federal access to care standards.
Sorry, I didn't hear what you said, the mask.
Oh, sorry. Suzanne Bierman for the record. As a part of effectuating any proposed rate changes, we would have to submit a state plan amendment to the Centers for Medicare and Medicaid Services. As a part of that process, they review and then approve or deny any state plan amendments that we make. And a part of that process is ensuring that there's still access that meets the federal requirements related to access under the Social Security Act.
So just a follow-up, I guess what I'm talking about is that, when we get sick or one of our loved ones gets sick, we all want to go to the best hospital. We want the best doctor, the best nurse, the best healthcare provider. But what are we going to do when we continue to chip away at the reimbursement rate for Medicaid to the point where there's the providers just can't make a living, and that will, in fact, affect the access to care for people who need it, for Medicaid recipients. I just wondered what your thoughts were on that. How's that going to play out in your mind?
For the record, Richard Whitley, it will definitely have an impact. It will have an impact on to the previous question of Assemblywoman Titus about private hospitals versus public or county hospitals. Private hospitals need a payer mix, and so if they happen to be geographically located or even in the urban areas in a corridor where there's people living in poverty who may have greater access, it does impact. It impacts their growth and expansion of specialty services. I think where the risk is in primary care and physicians that are able to make a go of it. We recently heard at the Governor's Patient Protection Commission a presentation by primary care providers who have had to essentially turn off services for the past several months because of the pandemic, and they're very much struggling already. And so, to your point, reducing rates will have an impact on providers, probably more dramatically on those that aren't connected to large systems, because they're out there on their own and trying to make a go of it, and they will probably take fewer Medicaid clients, or if they're relying on Medicaid and the rates are reduced, they may have to make business decisions. So we're in no way trying to gloss over this in any possible way or sound bureaucratic in terms of what the Medicaid rules are. It will present a hardship on providers, which will then impact consumers.
Assemblywoman Backus. Assemblywoman Neal.
Thank you, Speaker Frierson. So I had a question really quick on the optometry for adults. This was going to be eliminated as an optional service. What exactly is going to be eliminated? I know, are they not going to be able to get their glasses, the once-a-year glasses? What's the situation?
Suzanne Bierman for the record. Thank you for the question, Assemblywoman Neal. Yes, that is part of this proposal, is that the full current optometry benefit would be eliminated for adults, including eyeglasses.
Quick follow-up, Speaker?
Follow-up.
So, okay, I know you pretty much just answered this. So, okay, I just need to process this for me for a minute. So no eye exam, no glasses. Is there going to be an alternative for them? Or they just have to pay out of pocket? Can they still try to work out an arrangement with their existing Medicaid provider?
Suzanne Bierman for the record. Thank you for the question. They could try to work out an existing an arrangement with their Medicaid provider, but Medicaid wouldn't be providing reimbursement to that provider. Again, optional services are called that, and we do have the flexibility under the federal framework to make these tough decisions and tough proposals that would allow for the elimination of these services. But again, agree with you that just because it's optional doesn't mean that it's not necessary, especially if you're the person that is in need of this service.
Assemblywoman Monk.
Thank you, Chair. I had a question on one of the eliminations of services also, the psychosocial rehab services and the basic skills training. Does that mean that the people that are currently doing those services, they're going to be losing their jobs, or we're just not hiring new?
So for the Medicaid programs, it means that we would only be reimbursing providers for those services for children instead of children and adults.
Any other questions? Check the email. Councilman Carrillo, you sent the email. Do you want to ask a question? Or is it in a future section? All right. Any other questions? Oh, Woman Menez-Thompson.
Thank you, Mr. Speaker. And I think it's probably more just a comment, because there was a question asked about the Medicaid CARES dollars that were specific to the state, and why those weren't being passed along to providers. And so this, the Interim Finance Committee did set up a subcommittee that you chair that will be looking at those disbursements, something that the CARES Act did that is very different than what we saw in other federal packages of previous recessions, is the money didn't all land primarily in the state's pockets. The federal government was making direct disbursements to healthcare facilities. And one of the things that we're going to be looking at is where all of those dollars fell in the state. So, for example, there was money out there for telehealth. There was money out there specifically for hospitals and broadband. There were actually lots of facilities that did get direct disbursements from the federal government that just have been outside of our purview and how we look at money at the state level. I don't know if the department has more insight on that. I know we've been working hard to try to track to see where all those dollars fell. You might have more insight, but I know that that'll be work that this committee, a separate subcommittee, will be doing.
Correct. For the record, Richard Whitley, it really a matrix showing some of the direct funding that hospitals receive, and then what the impacts were during the pandemic, and if we the CARES dollars that come to the state that have been distributed for some targeted things, to reconcile all those in terms of where they land. We know that that's out there. We're, in all honesty, working in real time to meet the needs of people. We haven't as a department constructed that matrix to look to see who's benefiting and who's not. We've been really responding to the crisis, but that is available. That's public information on where those dollars go.
Okay. Other questions on this section? All right, seeing none, we'll move on to the next section. Director Whitley, you have the schedule?
Yes, the next division that you'll hear from is the Division of Public and Behavioral Health. And Lisa Sherrick, the administrator, and Dr. Woodard are going to present those reductions.
Good afternoon. My name is Lisa Sherrick, Administrator for the Division of Public and Behavioral Health. I'd like to go over highlights of our proposed reductions with our direct service programs. Specific to Southern Nevada Adult Mental Health Services, we are looking to reduce $8.4 million, of which is inclusive of vacant positions, freezing those, as well as residential reductions. This specifically includes 5 psychiatric nurses, which are vacant for our Ross and Neal Psychiatric Hospital, along with reductions to our residential budget, which will result in 270 individuals being displaced with housing. I would like to note each of these 270 individuals will continue to receive service coordination, medication management, therapy, etc., through Southern Nevada Adult Mental Health Services. The average service hours that these individuals do receive in the housing program is about 32 hours a month. So these individuals are more in the transitional type services and need lesser support than others in our more intensive programs. The remaining residential services focus for Southern Nevada Mental Health Services will be for individuals in the Justice Involved program, so assisted outpatient treatment and mental health court. I would like to note, while we have a reduction to our budget for mental health court, that budget in itself does include housing, transportation, food, and treatment dollars. And no client in that program will be losing any housing services. Our legislatively approved caseload is 75. We currently have 75 individuals in that program, of which only 46 require residential financial dollars to support their housing. So that is where we have the additional, if I can say, savings to be able to reduce from that category. Additionally, for Southern Nevada Adult Mental Health Services, we are reducing the community triage center dollars, which is $550,000. That is being reduced. We have not, there's been no community provider that has accessed those dollars in FY20 or in FY21. And I would like to note that the CTC dollars for Northern Nevada Adult Mental Health Services are not being reduced. Moving on to Northern Nevada Adult Mental Health Services, we are looking at about $1.5 million in reductions. Those are freezing vacant positions. This includes 11 outpatient positions being reduced, 5.5 of which are with our medication clinic. We have then additional 5.5 positions that include psychologists, mental health counselors, and a substance, a substance abuse counselor. We currently do not have a wait list for medication clinic at Northern Nevada Adult Mental Health Services, which serves 724 individuals at this time. And we currently do not have any wait lists for our counseling or service coordinator services, of which those vacant positions were reducing. Moving on to rural clinics, we're proposing a reduction of $1.6 million. Again, that is freezing vacant positions for FY21. Those include some positions in service coordination, social workers, and mental health counselors. And we do have wait list for our service coordination, which is at 16, med clinic at 18, and outpatient counseling wait list 32. We are restructuring our staff to be able to meet the needs in all the clinics to the best of our ability. And the caseloads have been going down naturally right now. However, I understand that it very well is due to COVID, and there is the possibility that those could go back up. Additionally, we do have one-time appropriations and other savings that we are looking to propose reductions to. First is SB 263, which is the tobacco prevention. This funding was to address tobacco and e-cigarette and vaping for youth, and that is $1.5 million. Problem gambling, which is funding covers prevention, public awareness, treatment, evaluation, workforce development, and research, and that is $1.6 million. Then we additionally have reserve sweeps, which is alcohol tax reserves at $500,000. Currently, there's no dollars obligated right now, so there's no impact for those dollars. Our healthcare quality compliance reserves, it's $100,000. This is our state monetary sanctions account. Again, no impact to services or positions. And lastly, we have our Attorney General Johnson & Johnson anti-vaping settlement funds, which is $1.7 million. This funding was to provide media public awareness on this topic. With that, I'm happy to answer any questions anyone may have.
Questions, Assemblyman Yeager.
Thank you so much, Mr. Chair. I have two questions. I'll try to make them quick, and I'll start with the more specific question. I wanted to ask about the problem gambling appropriation, and I guess before I get started, I want to acknowledge that these cuts are all difficult. I appreciate that. I respect this process. Problem gambling, the question I have is, it looks like, percentage-wise at least, it's a pretty substantial cut. Looks like almost an 80% cut from the appropriation that was made by the legislature. We heard public comment this morning that Medicaid often doesn't cover problem gambling unless there's a comorbidity, and that private insurance doesn't cover it often as well. The state really is the payer of last resort. So my question was just to get some of the thought process behind such a dramatic cut in the problem gambling arena. Again, I understand all these cuts are difficult, but just wanted to understand some of the thought process that went behind that.
Lisa Sherrick, Administrator for the Division of Public and Behavioral Health. So, you know, I completely agree with your statement about any and all cuts are very difficult. What we struggled with at this division was, you know, if we didn't look at additional cuts in other programs, then we would have had to dig deeper into Southern Nevada Adult Mental Health Services and Northern Nevada Adult Mental Health Services. So that really is the reason that problem gambling took such a significant cut, and it appears to be much larger than any other program.
Okay, thank you so much. And the second question was on the Southern Nevada Adult Mental Health Services. And I'm really delighted to hear that nobody who's in the mental health court program that is requiring housing support will be displaced from housing, because of course that's really important for them. I am curious though, I think at the beginning of the Southern Nevada Adult Mental Health discussion, you'd indicated there were 270 people who were not in the justice system, but who had been receiving housing support, and I think you said they were going to be displaced. So my question there, and I guess it's maybe a specific question and a more general question, the specific one being, what is the plan to help those folks who all of a sudden are going to lose their housing? And the more general question is, sort of with all these cuts that we see that are really going to affect people who are struggling to get by, is there a plan to help to connect them to other services in the community, whether it be local government resources or family resource centers? So if you could address that, I would appreciate it.
Certainly, Lisa Sherrick, Administrator. So for those individuals, the 270, they will still receive service coordination through Southern Nevada Adult Mental Health Services. And the role of those staff is to ensure that they're linking those individuals to community resources, making sure that their needs are being met to the best of their ability. We have, this morning, we did have or not me, myself, but staff at SNAMS did have a conversation with Clark County and the continuum of care to look at what options are available for those individuals. We are continuing to look at and have looked at individuals that have resources, how we can potentially pair them up with other individuals. Of course, you know, they would have to agree to that, but to be able to find other housing options and be able to share resources for that. With our program, we are still, with the service coordination, we still will be providing transportation supports as well as some personal needs supports. So while I understand that that is still not ideal and probably going to 100%, or I can't even say 50%, ensure that each of those individuals will not have an appropriate place to live. That is where we're at today, and we will continue to work as hard as we can to minimize the impact. We also have submitted CARES relief dollars to see if that's an option to help with the residential costs. And I know that that was also discussed this morning at that meeting, if that is an option for the county to apply, since it was in our budget. So it might be easier for another entity to do that. But we certainly are exploring all options.
Assemblywoman Carlton.
Thank you, Mr. Chairman. And, you know, when we start talking about cuts to mental health, mental health has always been a struggle for this state. We're ranked at the bottom right now. We were beginning to make ground in 27 and 8, and then the first economic recession hit us. And we have not gotten back to that level yet. We flattened out in 10. It dipped 11 and 12 and 13, but stayed stable. We found a stable point. And I believe what drove a lot of that was a lot of the press coverage where people were getting mental health by being handed a bus ticket and being told to go back to the state that they came from. There was a time when Ross and Neal lost its accreditation because we had not funded it correctly. So we've stayed flat through 13, 14, and in 15 took a terrible dip through 15 and 16. Budgets were severely impacted over that particular biennium. And we still have not recovered from that. In 17, we added an extra $22 million to mental health and worked very hard to add extra money to other budgets that were in the multitude of mental health budgets. I think the division has 27 total budgets that can be impacted. And in 18 and 19, we made significant increases again, but we're still not back to where we were in 2010 when we had made cuts. So to make cuts again to mental health, we're already at the bottom. We can't go too much lower. We will be setting the bottom floor of mental health coverage in this country. So I just think we need to remember where we've come from, how much we've gained, and we know all these cuts are devastating, but it always seems like they're multiplied when it comes to the mental health system. And we never seem, it takes us years and years to recover. So I hope as we move through these particular cuts, we can try to cushion them as much as possible. We're still 29% down on where we should be, 30% behind. So thank you, Mr. Chairman.
Thank you. Assemblyman Hafen.
Thank you, Mr. Chairman. My questions are specific to the rural reimbursement, specifically in regards to the critical access. Currently, my understanding is that Medicaid is a cost-based reimbursement, which is different than in the urban areas. And if you could just touch on how those reimbursement rates are going to be affected in the rural areas and the critical access hospitals. Thank you.
Okay. For the record, Richard Whitley, Director for Health and Human Services. So to that question related to Medicaid, the critical access hospitals are not impacted. Federally qualified health centers, the certified behavioral health clinics, the rural health clinics are not impacted.
Thank you very much, and thank you, Mr. Chairman.
Any further questions on this item? Assemblywoman Nguyen.
Hi there. Thank you, Chairman. I have a couple of questions. You were talking a little bit about mental health court, and just to clarify some of those numbers, you had indicated something about 75 of the people qualified for beds, but about 46 of them actually needed housing. Do you know if there's any flexibility if other individuals participating in those programs need housing?
Lisa Sherrick, Administrator, for the record. So correct, 46 of those individuals require financial support for housing, whereas the remaining 50 for the 77, the 75. Apparently I can't do math when it comes to testifying, so I apologize. But the remaining of the individuals, there are individuals that have employment and they have housing currently, but they do go into the mental health court program to receive those additional services to work towards the program assigned through the judge process. So I don't know if that answers your question, but there is a mix. So there's some that do require financial support, of which we do have funding for, and then there are individuals that require that support financially for housing.
May I follow up, Speaker? So is there wouldn't be any flexibility if you had other individuals that needed housing assistance if those numbers like shifted? Is that correct?
Lisa Shark, can you repeat that question?
If those numbers shifted and instead of being, 46 people that needed the services, it was now 75 people that needed the services, there would be no flexibility in that spending.
Lisa Sherrick, for the record, no, we would make sure that the individuals did receive housing supports, financial supports, and we would prioritize them. Historically, the Southern Nevada Adult Mental Health Services has reverted dollars from the mental health court budget. So I could look back and see, but I don't believe it's ever been 100% of the individuals at any given time required that financial support. There's always been a portion of individuals that have their own stable housing.
Thank you. Assemblywoman Neal.
Just skip me, I don't remember my question.
Assemblywoman Hanson.
Thank you, Mr. Chair, and thank you for being here today. Yes, this is a difficult task before you and us today, and I think we all share the same concerns about the state of mental health in Nevada. We see it across the board through the courts, in our schools, in the public at large, and so this is no easy matter. I did want to clarify, as I look through some of the bigger cuts, the Southern Nevada Adult Mental Health, the 10 million, just to clarify, that's essentially you're holding 8 positions. It's not necessarily services that will be impacted, although if you don't have the staff, I guess it impacts your services. But as I look at the big ones, the 10 million there, let me go to the next page. What was the other one? There was the Northern Nevada Adult Mental Health, 2 million, hold 15 positions. And then on to the next page, the rural clinics, defer the start date of 11 3/4 positions. So am I to understand that those, you're looking at just holding back from staffing, services will continue, but on a greater load for the employees?
Lisa Sherrick, for the record, yes, that is correct. There would be no service reductions, with the exception of the housing that I provided the overview for that the rest of the services will stay intact. And staff, yeah, and it could increase wait lists. It could cause an increase in quality issues. So we definitely are concerned of that and mindful of that. But to try to salvage services, that is the decision that we made.
And I appreciate that. I think it's interesting that, the departments have been asked to, you know better. You're there. Your departments know where could we, if we have to cut in these drastic times, where do we make those cuts? So I appreciate that you're trying to keep services intact. If I could follow up with one other quick question about the problem gambling. I'm not familiar with how that's funded per se. Curious if the gaming industry pays into any of those funds at all to help with services.
Thank you for the question, Stephanie Woodard for the record. So the funding that it's generated that pays for those services is a $2 slot tax, and it's per slot machine, but the definition of what qualifies as a slot machine that's in statute is relatively narrow. Last session, there was an attempt to expand on funding because the taxes have actually gone down related to the $2 slot tax, which would have been a 0.6% tax on gaming in general. That did not move forward, and so we have remained relatively flat with some decrease in the amount of funding that's been available for problem gambling.
Thank you.
Any further questions? Assemblyman Ellison.
Thank you, Mr. Chair. And I don't know if this is something you'd know or whatever. Does the smoking, the tobacco fund that comes in, does that have a cap on it, or does it keep on going long as payments keep coming in from the cigarette industry? That's one of the questions I've got. Can you answer that?
Lisa Sherrick, Administrator. Yes, it does.
It does have a cap on it, or it keeps on going?
Lisa Sherrick, it keeps on going.
Okay.
Or accruing.
Okay, and is that, did you say that the vaping also pays into this?
Lisa Sherrick, Administrator. I don't believe I said that. And so are you talking about SB 263, the tobacco prevention, or just to clarify, that's the one that you were talking about, correct?
Right. You see a lot of people doing a lot of vaping. I didn't know if that was something that's going to be included in that or if something's already there.
Stephanie Woodard for the record, it includes, it expanded the sales tax from straight tobacco products to include e-cigarettes.
Thank you very much.
Assemblywoman Neal.
Thank you, Mr. Speaker. I had a question on the cocooning project. I wanted to get a little bit more information about the cut that's happening there for women that is, I guess they're post-birth for the influenza vaccine.
Lisa Sherrick, Administrator for DBPH. Yes, we are doing a cut in that that budget as well, and I'm looking for the exact number. I know it was over $100,000. Really, we're looking at reducing funds from this amount. So reducing funds from this amount will reduce the amount of Tdap and influenza vaccines that can be given to uninsured and underinsured mothers immediately after birth. The amount for FY21, the reduction is 148,911. You know, of course, we have a lot of concerns with that as well, and we have discussed other options as far as accessing FQHCs and things like that. But that is an area that we are highly concerned about, and continuing to determine how we can make sure that those women have access to those vaccines. I will say though, as of June 1st, 2020, the immunization rate among 24-month-olds was about 64.7%. So we definitely still can improve in that area, but I also wanted to provide that information. I don't know if that answered your question.
Chair Speaker, can I have a quick follow-up? So what I'm wondering is, you know, as we move into flu season, right, in the fall, and then now with COVID on top of that, was the reduction a complete elimination of the money, or will there still be something in there, or can CARES dollars help to maybe offset, being that there is some kind of correlation between prevention of influenza and a higher, you know, trying to prevent, you know, someone from coming down with both?
Lisa Sherrick, Administrator. So the program receives about $500,000 of general fund each fiscal year, and they've been receiving that since the 2013-15 biennium. So there will not be a complete elimination of those dollars. It would be a reduction. And, you know, we have looked at other opportunities to access CARES funds in the child maternal health programs. And I did receive some analysis or requests a day or two ago, and I'll have to double check to see if it includes this piece, and I can follow back up with you if that's okay.
Thank you. That's it, Speaker.
Assemblywoman Monroe Moreno.
Thank you, Mr. Chairman, and thank you for the presentation today. I just had a question about the Southern Nevada Mental Health Services. Along with the 8 positions, there's an elimination of a program, which is the Total Recovery Program. Is there any way you could just give us a little bit more information on that program? Is that just funding of a program within the county, or those people in the program, how will they be impacted? And will there be any other option for the people who are in the program?
Lisa Sherrick, Administrator, thank you for that question. So the Total Recovery Program is a 90-day substance abuse treatment program. It is, so it'd be kind of that transitional type program that is part of these residential cuts. They do have different options for housing, whether it's a CBLA or community-based living arrangement, group home, or independent housing options. There are currently 6 individuals that are receiving services in those programs, and they have been naturally attritioning out of that program. For individuals that are court committed, though, that are also utilizing those services, they would continue to receive housing services to fit their individual needs through Southern Nevada Adult Mental Health Services.
Thank you.
And Stephanie Woodard, for the record, I just wanted to offer some additional information. There are additional dollars that we use through the Division of Public and Behavioral Health through the Bureau of Behavioral Health, Wellness, and Prevention, which is a combination of state general fund and federal funding, specifically for either mental health services or substance abuse treatment services. Many of the individuals that would be eligible for the Total Recovery Program may also be eligible for residential services and some of our other substance abuse treatment residential service programs that are funded out of the Bureau of Behavioral Health, Wellness and Prevention. So it is likely that they would be able to access those services, though not directly within this program, with other providers in the community.
Thank you so much. It's encouraging to hear that there's other options. I hate to see those people just left out there and we not have another way for them to receive help. So I appreciate the answer to the question.
Assemblyman Fumo.
Thank you, Mr. Speaker, or Chairman. I have a couple of questions. First was, were you told a specific amount that you needed to cut the budget by, or a specific percentage?
Lisa Sharrock, for the record, 14%.
Can you repeat that?
14%.
Okay, and who told you you had to cut it by 14%?
Lisa Sharrock, that was from the governor's finance office.
Okay. Recently in Las Vegas, Sheriff Lombardo was on the news on Channel 8 and said that he spends a significant amount of time dealing with homelessness and mental health issues, and I would imagine most of the people he deals with end up needing your services or getting services provided by you anyway. He said he would divert a significant amount of his budget to taking care of that if he didn't have to deal with it anymore. And I guess my question to you is, has his office reached out to you, or have you guys been in communication with each other to work on that plan?
Lisa Sharrock, Administrator. I have not been aware of that, but I am more than happy to get his contact information today and have a conversation.
Excellent, thank you.
Other questions? Check the email. All right, seeing no other questions on this, it appears, Director Whitley, if you want to move on to the next budget item.
Hi, for the record, Richard Whitley. Our next budget is, our next division is the Division of Welfare and Supportive Services, and with me is Steve Fisher, and Steve will go over the reductions in the Welfare Division.
Good afternoon, Mr. Chair, members of the Assembly. Thank you for the opportunity. For the record, my name is Steve Fisher. I serve as the Administrator for the Division of Welfare and Supportive Services. And our division provides eligibility for the Supplemental Nutrition Assistance Program, Medicaid, Temporary Assistance for Needy Families, Child Care, and the Energy Assistance Program. And as soon as the emergency declaration occurred, our agency quickly, within 5 days, we transferred 1,800 of our staff to a work from home model. And we didn't miss a beat. And we continue to serve low-income Nevadans and those who've been impacted by COVID-19. We continue to serve them. And so I just wanted to give a shout out to our staff for a great job. Going through our reductions, the first one here is really it's the fund salary costs for field services, eligibility staff, and eligibility supervisors using CARES Act funding. And this, back in April, as soon after the Department of Treasury issued their guidance on CARES Act relief funds, we worked with our Deputy Attorney General, who reviewed the guidance and confirmed that our staff, eligibility supervisors were eligible for this funding. The second item on the list is a reduction to general fund match in our child support enforcement program. The division has what's called state share of child support collections. These are made on behalf of families receiving assistance under the Temporary Assistance for Needy Families program. And those funds exceeded projections, therefore reducing the need for general funds in this particular budget account. And lastly, we have reductions in our administration budget. 15 or 16 vacant positions we're going to freeze. elimination of travel and training, operating cost reductions, and information services reductions. And with that, Mr. Chair, that concludes my overview, and I'll be happy to answer any questions you might have.
All right, questions? Assemblywoman Carlton.
Thank you, Mr. Chairman. So I'm just going to jump into a couple of things that I just think we need to get on the record. I know that the division will be receiving or has received CARES Act funding that may be used to pay for targeted salary expenditures. Do we know that amount, and when will it take place?
The record, Steve Fisher. We are making the dollar amount is, the total dollar amount. Pardon? So the total dollar amount, Assemblywoman Carlton, is $40 million that we're requesting in CARES Act funding. There will be a process that we will need to go through to request those CARES Act relief dollars. We'll have to make a request to the governor's finance office, justifying obviously those expenditures to be able to receive those funds. And so I hope that answers your question.
So I'll elaborate a little bit more because I may not have asked it quite in the fashion that I needed to. It's getting later in the afternoon. We've been at this for a while, for a couple of days. So it's my understanding that the governor is going to recommend using about 14 million of that amount in CARES funds to pay for a portion of the salary costs. And I was just wondering if that was clear, and if we could actually use those monies for those reimbursements right now.
For the record, Steve Fisher, Administrator for the division. The total dollar amount that we're asking for is $40 million, which will save $14 million in general fund dollars. And so I have reached out to, I've gone through a process. So at the very beginning, obviously, I worked with our Deputy Attorney General to make sure that these funds are eligible. I've reached out to the Centers for Medicaid and Medicare, Nutrition Services, to also ask them if these funds are available or eligible, and they've directed me to the Department of Treasury. And so I do want to give a shout out to State Treasurer Conine, who has a conduit to the Department of Treasury. We have made some requests to the Department of Treasury. We're still waiting for feedback and guidance directly from the Department of Treasury. It's pretty clear in the guidance that there is no approval process. They have left it up to essentially each governmental agency to determine what is eligible and what's not eligible for the CARES relief funds. But however, we have made a couple of requests to the Department of Treasury, and we're waiting for those responses. I can confirm that our eligibility workers and our eligibility supervisors are certainly vital to protecting the public health of Nevadans by providing eligibility, as I stated, for Medicaid and SNAP, and that our staff are substantially dedicated to mitigating or responding to the COVID-19 public health emergency. And that's one of the major requirements, is that your staff, your employees have to dedicate a substantial amount of their time to mitigating or responding to COVID-19 in order for them to be eligible for the reimbursement. I mean, our eligibility workers are frontline essential staff who are providing low-income families who've been impacted by COVID-19 Medicaid benefits so they can seek testing, treatment, and SNAP benefits to address food insecurity for those who've lost their jobs. Certainly during this event, our eligibility staff have been required to learn and adopt and implement substantially different policies, guidelines, and significant changes to our eligibility system to provide services to a substantially different population while utilizing a completely new work from home business model. And I think the point I want to make there is they're their jobs have completely changed. This has changed their jobs. In the month of April, we added over 70,000 SNAP customers and over 24,000 Medicaid. Going back through our historical caseload data, going back to 1999, the largest one-month increase I could find was 37,500, and that was back in 2014. So in 1 month, our staff provided services to almost triple the number of Nevadans in 1 month, going all the way back to 1999. So this is certainly an example of our staff's substantial dedication to responding to COVID-19. And so hopefully that answers your question.
Yes, thank you very much. We're still waiting on confirmation of the 14 million, but it sounds like you feel fairly confident, and since those employees were designated as essential and were performing those duties, hopefully that will come through. So when it does, if you would just let staff know so that they can make sure that the committee is aware that those dollars will be able to be accessed for that purpose. Thank you.
For the record, Steve Fisher, yes, I will do that.
Thank you. Assemblywoman Tolles.
Thank you, Mr. Chair. And I just have two quick questions. One is in regards to looking over the juvenile correctional facilities and seeing that there's a reduction in the beds available, and just wondering what happens when we have juveniles that we need to place with those reductions in the we how we accommodate that.
For the
record, Richard Whitley, we actually, if I can have Administrator Armstrong respond to that, but that actually was intended to be our next presentation on child welfare.
My apologies, I jumped ahead and put them together. So then let me just jump to a quick question specifically on page 13. So looking at the administrative cuts, 0.6 million, and under operating costs, I know that we use outside contracts. Are we, have there been any cuts to outside contracts, or is that all internal? Thank you.
For the record, Richard Whitley, it's primarily internal savings. We have delayed some of our IT projects, however, that won't do harm but can be delayed.
Thank you.
And I would just add again, for the record, Richard Whitley, that it doesn't result in any layoffs of staff.
Okay, any further questions? I see none. If we could go on to the next budget item, Director Whitley.
Sure. The final division that we have today is the Division of Child and Family Services, and with me is Ross Armstrong, the administrator of the division.
Good afternoon, Ross Armstrong, administrator of the Division of Child and Family Services. We have our reductions come in three major parts. The first being child welfare, which includes reductions in child welfare incentive funding for Washoe and Clark counties, vacancies for our rural region child welfare agency, and then a transfer of our Unity, which is our computer case management program, costs from the general fund to a federal grant, a new federal grant that has come out. In our juvenile correctional facilities, we're freezing 53 currently vacant positions, and with that reducing the total capacity of our facilities from 224 beds to 160 beds. And then in child and adolescent services, which is children's mental health, freezing 11 vacant positions across the state. And so I'm happy to answer any questions at this time.
Assemblyman Carrillo.
Thank you, Chair. Thank you, Mr. Ross. My question's on regarding how many kids are currently receiving outpatient therapy but will lose their therapist in the division reorganization.
So, Ross Armstrong, in terms of the child and adolescent services reductions, there are, well, let me say this. Our original proposal to get to 14% had us eliminating 60 positions in children's mental health. And so when we talk about the sweeps and some of the other measures that the governor's finance office and the department took to reduce layoffs and to minimize the harm, I can point to 49 staff that will remain and the families they serve. And so in early childhood, it's 3.5 full-time positions. In children's clinical, it's 3.5 positions. And for rural WIN, it is 4, depending on the service provided. Those caseloads are about 20 families is ideal. So with the small reduction to children's mental health, we won't be throwing any current clients off the caseload because they're not positions we're laying off. We will be taking a hard look at the families that come to the Division of Child and Family Services for assistance and making some decisions about whether they're best served by the division or by community providers. Thanks to the expansion of Medicaid, we have less and less kids who are not covered by Medicaid, which has traditionally been where DCFS serves those who don't have coverage. In addition, we heard today about the growth of federally qualified health centers and the CCBHCs, which can actually meet the more holistic needs of the family in terms of meeting all of their health needs. And so we'll be taking a look at the incoming cases and making determinations about whether we or a community provider might be best suited for them. So because these are no layoffs and they're just frozen vacant positions, no families will lose their current DCFS therapists.
So you're saying that there's no plan to reorganize the division past this current plan, correct?
Correct.
Okay, and my follow-up to that is, so on these freeze of 11 vacant positions, and you're saying that no more layoffs are expected, and what happens if the plan isn't enough? I mean, are we going to go back and look at that? I know some of this stuff isn't really written in concrete, but if you can kind of elaborate to that.
I can. If we're requested to come up with more cuts, towards the beginning of the presentation, Director Whitley laid out the department's approach at the division level. We prioritized those services that are statutorily mandated and those that are safety services as well. We also took a look at current operations. So I can't say that if we're asked to come up with more cuts that they won't be in children's mental health. We'll evaluate the cuts just as we have throughout this entire process.
Thank you, Mr. Ross. Thank you, Chair.
Thank you. Senator Flores.
Thank you, Chair. Regarding the juvenile correctional facilities, specifically the 53 vacant positions, I'm just trying to understand how long have those positions been vacant? Are they fairly new vacancies, or they've been sitting there for some time now? And then if you could just give some perspective specifically as to what those vacancies are. In other words, these are correction officers or their mentors or, whatever it may be. I'm just trying to understand what those positions are.
Sure, Ross Armstrong for the record again. Some of you may have remembered last session, we asked for a substantial increase in staff to meet the Federal Prison Rape Elimination Act. And so some of these frozen positions are those new staff we received last session. Some are just part of the natural flow of vacancies we have in this particular group. It can be difficult to hire. Our wages are not competitive compared to the local county juvenile justice officials, and at least in Caliente and Elko, you have pretty rural areas. And so we have a vacancy rate that typically fluctuates about 15% or so. And so what we did when we took a look at the capacity of the facilities, one thing is we wanted to maintain that PREA compliance so that the state didn't get a penalty of federal funding. If you are not PREA compliant, you receive a penalty in terms of some grants for victims and others that are related to that. And so what we've also actually seen is a reduction. So last year, for the entire calendar year, our average daily census at our 3 facilities was 150 youth, compared to in the low 200s before that. We currently have 154 youth in care now. And so as we went about taking a look at the cuts, we looked at the current operational need and demand, and this was one area we thought that we could make a reduction without much harm. To answer your second question about what type of staff they are, these are all what we call group supervisors. For lack of a better analogy, they are the juvenile justice facility version of correctional officers. Summit-View Youth Center has correctional officers. That's our maximum security, highest level facility. So the correctional officers are not affected there. We maintained our mental health counselors, our teachers. We run the high school at Nevada Youth Training Center, so we actually employ teachers that are our staff. Although we're reducing the bed size, the challenge will be to make sure that we're doing a greater job at providing the services needed for the youth while they're there.
Thank you.
Assemblywoman Backus.
Thank you, Speaker. And Administrator Ross Armstrong, I had a question kind of following up with respect to the juvenile correctional facilities in light of hearing that Clark County may shut down our Spring Mountain Youth Camp due to also budget issues and the number of children that may be being served through juvenile justice. One of the questions I had was there any consideration of maybe closing down the Nevada Youth Training Center and reallocating those resources further south to Caliente Youth Center and Summitview Youth Center, kind of in light of twofold, the history that we had stemming from Nevada Youth Training Center for the children from Clark County, and also in light of services to be provided to females. I believe only Caliente provides beds for females. Thank you.
Ross Armstrong, for the records. We took a look at how to allocate the beds. The youth that are committed to the Division of Child and Family Services benefit greatly from having 3 options to place them and to make sure that the facility that they reside at can best meet their needs. So what we see with youth who are a great fit for the Nevada Youth Training Center that would have difficulties if we were to shut down that entire facility are those who need flexible and creative educational solutions. The other 2 facilities, we contract with a local school district to provide the education. And so at the Nevada Youth Training Center, if we have a youth who has particular struggles with traditional educational model, they really excel well at the Nevada Youth Training Center. You are correct that the Caliente Youth Center is currently the only facility that receives girls. We have seen a reduction in girls committed to us, and we would continue to try to work to make sure that the girls, a majority of whom have experienced some sort of trauma and in a lot of cases sex trafficking, that there's a better therapeutic placement for them rather than correctional care. In terms of the history from 10 years ago or so at the Nevada Youth Training Center, we have an objective evaluation of our 3 facilities that are completed every year, twice a year actually, and currently the Nevada Youth Training Center is our top performing training center in critical outcome measures, including safety, security, and health. And so it did not make sense to shut down our current top performing facility.
Assemblywoman Cohen.
Thank you, Mr. Chair. I want to ask about funding for foster care and adoption.
incentive funding. Can you address how this, the reduction in incentive I'm sorry, can you address how the reduction in incentive funding will affect foster care and adoptions?
Absolutely. This is Rob Armstrong, again, the Administrator for the Division of Child and Family Services. The funding of our child welfare system is a real patchwork, and Nevada is unique in the country, really, in terms of having our split system with Washoe and Clark operating their own agencies and the state operating the rural. The incentive funds that were listed in the cut are established in statute. They're completely general fund. And it's a fund where Washoe and Clark counties submit a proposal each year that tries to focus on improving their systems, innovating their child welfare system. And then if they meet the benchmarks they set for themselves, they receive that incentive payment. So it is not the same budget line item as adoption or foster care payments. For child welfare, the block grant, the caseload-based funding, all of that is preserved. It's this very flexible incentive funding that was the one that was easy to, not easy, but was the easiest to reduce without substantial impact on individuals. So foster families, adoptive families, they will not be receiving cuts. There'll be some less flexibility for those two agencies. It's not a complete zeroing out of that budget, so Clark County will still receive $1.7 million in incentive funding, and Washoe County will receive $577,000 in incentive.
Thank you.
Assemblyman Ellison.
Thank you, Mr. Chair. I've got a couple questions about the youth programs. If you look, you've got Caliente, you've got rural child welfare, and it's calling for 5 positions to be cut. But the one that gets me the most is one of the ones that we've spent a lot of time at, which is the Nevada Youth Training Center, and you touched on it about how well their educational program is. It's one of the best. These guys come out with full degrees or high school diplomas, and they move on and do a good job. They also get job programs offered with the forestry and some of these other ones for firefighters. But one of the things that I'm looking at, the capacity from the 48 to 13, have you talked to the supervisors out there, and what about the safety for the supervisors also? Because these are some of the roughest guys when they first get there. They can actually do pretty good after they leave there. Could you answer that?
I can. Thank you, Assemblyman, for the question. One of the reasons you see that we've been very transparent in terms of the reduction in capacity is that we didn't want to just freeze positions and maintain the same capacity. I don't think, especially at Caliente and Nevada Youth Training Center, where we have the biggest reductions, that we would be able to maintain the same level of safety we are now, which at some times, depending on the milieu of youth at the facility, can be tenuous, on the best days. And so that is why you see the reduction in capacity and not just the freezing of positions. So the Federal Prison Rape Elimination Act ratios, the required ratios of staff to youth is 1 to 8 during the day and 1 to 16 at night. And so we're able to preserve those ratios with these reductions.
Sorry, thank you. The Carlin camp that was supposed to go over to the Youth Challenge in Carlin, Nevada, with that going over the way it was supposed to open, will they still be able to maintain the grant that they've got to open that up for the children?
This is Administrator Ross Armstrong. That actually, I think, is a question for the military folks. That is not under our jurisdiction at all. We'd work collaboratively with the proponents if they needed assistance with the school to see what assistance the school at NYTC could provide them. And and any sort of technical assistance or guidance we could provide them in operating a facility for at-risk youth. So I am not sure what the status of that facility is, if it is still a go, which I believe the bulk of that was federal funding. They needed to meet certain benchmarks to show a willingness of the state to operate that. If that is still a go, then we, of course, continue to extend that offer of technical assistance.
Thank you.
Assemblyman Fumo.
Thank you, Chairman. You may have answered part of this question with your answer for Mr. Ellison, but I'm going to ask it anyway. I'm looking at page 14. I see that you are reducing beds at Caliente Youth Center from 112 to 64 beds. Nevada Youth Training Center from 64 to 48 beds. Summit View, you're going to maintain, and capacity change will be 224 to 160. How is that going to save the state of Nevada money? The reason I ask that is because I had asked before in another meeting about reducing beds at the adult prison. Florence McClure Prison for women in southern Nevada has 90% first-time offenders, nonviolent, and I suggested reducing that population to, say, house arrest, where they're actually out getting day-to-day, day-for-day credits. And I was told that unless you actually close the center, you're not going to make a negligible shift in the money. How is it that the adults can't do it, but the youths are required to?
So this is Ross Armstrong. I can't speak to the Adult Department of Corrections. In terms of the savings, the freezing of the vacant positions, again, they're currently vacant positions, is $3.6 million in general fund. Medicaid considers our juvenile individuals that are at our facilities just like adult prisoners, and so they're not eligible for any sort of Medicaid reimbursement or assistance, really, with the exception of some very small federal education grants to help those facilities. So they're almost entirely general fund operated. And so that reduction of general fund is all in the freezing of those staff positions.
I understand that, but how come it'll make a difference with the juveniles, but it wouldn't make a difference with the adult?
Again, this is Administrator Ross Armstrong. I can't speak for the Department of Corrections. I know that the reduction for us in terms of the staff freezes and the reduction of capacity is $3.6 million.
May I follow up? You're just not going to hire anybody new, but the reduction in the amount of beds, will that significantly make a difference? Or is it just that you're not going to hire any new people because you're reducing the bed quantity?
This is Ross Armstrong again. Some of the day-to-day operational costs at the facilities are not that elastic, so it costs similar to the dependent. There is a greater savings if you completely shut down a facility. However, in terms of not hiring folks, the biggest savings is in the supervisory staff that we have. We will continue to monitor. There may be other savings, in contracts and food and that type of thing, in terms of the reduction. But this is primarily focused on freezing those freezing those currently vacant positions.
Mr. Armstrong, if I can follow up, I think I understand Assemblyman Fumo's concern. Is there a ratio, a mandatory ratio for staff within the juvenile detention facilities that doesn't exist in the adult facilities, if you know, which might account for why with the adult facilities it's different than with the juvenile facilities?
Correct. So this is Administrator Armstrong again. The federal PREA standards require that 1:6 and 1:18 ratio for juvenile facilities. There is no ratio whatsoever for the adult prisons and their compliance with PREA. Their ratios are astronomical compared to ours.
All right, thank you. Assemblywoman Douglas Boone.
Thank you, Speaker. You mentioned earlier that CCSD teachers and supports are a part of your staff for the Caliente and Nevada Youth Training Center in Summit View. My question is, are you concerned or prepared for those cuts that might cross over with programs whose services will be, who cross over and whose services will be reduced on the CCSD side? Thank you.
Administrator Armstrong again. So to clarify, for the Summit View Youth Center, it's with the Clark County School District. For the Caliente Youth Center, it's with the Lincoln County School District. And we certainly do have concerns, more so with Caliente Youth Center. The school that operates there is such a bigger portion of the population of the county than is Summit View Youth Center. And so we'll continue to work with Lincoln County School District to figure out the best way to maintain that education, given the cuts. We have a great working relationship with the principal who serves Summit View Youth Center. Dr. Rugemer is amazing for us from the Clark County School District. And so we'll continue to work collaboratively. They've been great in terms of working through the restrictions in terms of COVID and really tailoring their education to this unique population. And so we anticipate that that in spite of the coming reductions for education, that working relationship will continue to benefit the kids we have living in our facility.
Follow up. So, but my question is, do you have a plan in place if CCSD cannot fulfill their end of the bargain or whatever contractual agreement you may have? Are there resources put in place right now? Are you working on it to be able to service the young people?
Administrator Armstrong again. So to clarify, the contract we have with each of the school districts primarily covers those summer months. Our average length of stay at our facilities is 6 to 9 months. And so if you have a youth come in at the beginning of summer and you have the traditional summer break, they are not going to have education for that half of their stay with us. And so they're required to provide those educational services during the traditional school year. If there was a reason that they cannot meet the contractual obligations during the summer, we would definitely have to come up with a plan. Neither of the school districts has notified us that with the potential cuts that would be the case. Again, we do pay for that funding out of general fund, and so we don't have projections in that contractual funding.
Follow-up question, please. So with CCSD proposing their plan this evening and their reopening plan, how will that affect the educational process for those young people that are going to be there when school starts back in your facilities? Thank you.
This is Administrator Armstrong, and I would have to take a closer look at exactly what that reopening plan is. Our school, they come on site to the facility, and so it is far from the traditional school setting to begin with. We have increased our ability to do video and remote resources, primarily to ensure that family engagement has continued during the COVID crisis. And so to the extent that the school would need the flexibility with some of those remote learning possibilities, we would tap into that. But I would certainly have to take a closer look at what that reopening plan is and understand if there's how it looks differently for the correctional care youth versus the regular community schools.
Assemblywoman Tolles.
Thank you, Mr. Chair. And just wanted to turn my attention. I think we've covered my question from earlier with various members. So if I could turn my attention to page 14 in regards to the child welfare cuts of $5 million, as we've expressed concerns over the increase in mental health needs. There's also been an increase through COVID in issues concerning areas of abuse and domestic violence and so forth. So certainly concerned about our children's welfare, as I know you are. I'm just wondering if there was a discussion about using TANF reserve dollars to help to lessen those reductions for the child welfare incentive funds. Was that something that was discussed?
This is Administrator Armstrong, and absolutely our Family Programs Office, which acts as really the oversight body and policy and resource hub for our 3 child welfare agencies, have worked with connecting both Clark and Washoe County with the Division of Welfare and Supportive Services to see what can be done in terms of using TANF to help support it. We, anticipating these cuts, we asked that their incentive applications that they submitted to us this year aligned with TANF allowable activities. And so we're continuing those discussions with DWIS. In addition, we have a request into the governor's finance office for the use of CARES funding for unanticipated additional costs related to the COVID situation, including the ability to do more effective mobile visits and a number of unanticipated needs related to the COVID, so that we don't have the extra COVID costs then piling on top of the reductions. And so we're hoping to hear from the governor's finance office soon on that application for CARES funding. In addition, finally, I would say in addition, child welfare is really being commanded to change the way it operates and adjusting from a primarily reaction-based system to focusing more on prevention. And so the Family First Prevention Services Act allows, it turns on federal funding for prevention services to prevent the removal of children in the first place. With that, the federal government passed the Family First Transition Act. That act has some funding to help shift a lot of our activities from just response to prevention. And I believe you'll see a request at IFC this fall to access that federal funding and start to spend it. So we are looking at every opportunity we can to pull in resources other than the general fund to support our child welfare agencies.
Thank you. So if I heard you correctly, it sounds like there's still a few things that are currently in mid-discussion that may reduce those cuts.
That is correct.
Thank you.
Assemblywoman Benitez Thompson.
Thank you, Chair. Just two quick questions. Last session, we had made some investments into rural child welfare. There was very much an interest in trying to open up more satellite offices. I think specifically we were trying to get one off the ground in Pahrump. And I know that we are going to hold back some vacant positions. I was wondering if you could, I was just curious if it was going to be those offices we were hoping to bring services to in that community, or if they were going to be, if there were vacancies elsewhere.
Administrator Armstrong, yes, one of the big investments was in bringing the intake process in-house, so we could do a better job of bringing in intake, and then expanding some of those workers, especially for those older youth in Pahrump, those transition-aged youth. And so the positions are casework management specialist, which is a classification that was created a couple years ago to help. We had a tremendous problem with vacancies in getting licensed social workers into those positions. And so the rural region staff are prepared to, as vacancies come up, make sure that the staffing meets the need locally where it is. And so we don't have necessarily them pegged for particular areas. It's not like all 5 are going to be from one office and we're going to leave one community not served. And so we appreciate the additional support last session, and we'll continue to spread the vacancies out to the places that can absorb them the most.
Okay, so through those rural regions, then it'll just kind of be a decrease per office versus closing one particular office.
Correct.
Thank you. The other one I had, it's just because I've got 2 different notes here that I want to reconcile, and this is on the Northern Nevada Child and Adolescent Services. So in one set of notes, I have language that just talks about a reduction, but in another set of notes, I've got language that says elimination. And so I just didn't know, are we with that 700, just shy of, just over $800,000 in reduction in funding between our general fund and our federal funds? Is it reduction or elimination?
Administrator Armstrong, so the original proposal to get to the 14% would have been an elimination, a complete elimination of children's clinical and an almost total elimination of the early childhood mental health. With the changes that occurred as we approached the session, again, I think in large part due to the savings realized by furloughs and then sweeping some of the accounts we've talked about today, really that catastrophic elimination has been avoided. And so there is that reduction of those 11 positions, but those, the vast majority, the bulk of those services will be able to remain in place.
Oh, good. Speaker, Chair, I do have one more. Would it be okay if I just snuck it in now? Thanks. So the question is on, I see that we're going to be pulling back the incentive payments in child welfare to Clark County and Washoe County. And that's of course really hard because we really have some metrics that we want to hit in that child welfare world to try to get kids back home if we can. But I know also that we made investments into childcare supports, and I don't think I see that money being pulled back, which would be a good thing. So I just kind of wanted to confirm if those investments we made are going to be able to stick.
Administrator Armstrong, for the record, those investments are preserved and they're not slated for reduction in this proposal.
Sorry, if you guys aren't standing up in the regular assembly, I can't tell when you're done. Assemblyman Roberts.
Thank you, Mr. Chair. A couple questions, and it kind of piggybacks on my colleague from 8021 talking about the juvenile correction facility budget cuts and the beds. And so you mentioned earlier in your presentation that you had 53 vacant positions that you had difficulty filling, and then you broke down the reduction in beds by these facilities. My first question would be, were these vacant last year, and what was done with the funds from the vacant positions last year? And then are these really, if it's an ongoing issue with hiring positions, is it really a budget reduction? Is it easy just to wipe off the 53 vacant positions? And if maybe you thought about closing a facility, or why you couldn't close a facility and apply some of that savings to the 5,000 in child welfare, or 5 million in child welfare. Just kind of curious if you could walk us through your decision-making process on those, and if I'm right on that.
Sure. This is Administrator Armstrong, and so our facilities, our juvenile facilities, have what I consider like a natural, not healthy, but a natural about 15% vacancy rate, depending on different circumstances on the ground. That fluctuates up and down. And so the funding from last fiscal year that was saved from those vacancies was reverted to help cover the cost of the shortfall for last fiscal year. It's really a natural reversion that is reverted each year. And so in terms of how we decided what capacity to go with at each facility, some of that was based on the current ability to staff the facility. The Caliana Youth Center, for example, has had difficulty in getting enough staff to hit the 112 beds since it was approved during the last session. They've fluctuated around the 80 youth mark in terms of having enough staff. In our smaller reductions, the reduction was to 80, but to get to the 14%, the cut to 64 was made. They're all done in those increments of 16, so that we could comply with the Prison Rape Elimination Act and maintain the safety and security of the facility. So they were done, again, in those chunks of 16 to meet those federal requirements. And we took a look at historically each facility's ability to staff at that certain level.
Follow up, Mr. Chair. So did you move any people around to facilitate the dropping of the beds, or this was just basically the way business is running now?
This is the way that business is running now. We did not shift anyone around depending on the level that it was dropped to and the number of vacancies. There's different percentages of changes at each facility, but currently there's 70 youth at Caliente, 40 at NYTC, and 45 at Summit View. So we would going forward shift additional youth to the Nevada Youth Training Center. But total wide, our average daily population last year was right at 157. We're at 150, actually 154 today. I think we had a youth go home today. So we believe that 160 beds will work out.
Okay, thank you.
Assemblywoman Torres.
Thank you, Chair. I had a question. You just answered one of the questions about how many beds you currently have available. And I was just wondering what the plan was. If the juvenile facilities do become full, what is the plan to ensure that these students continue to receive the resources that they need?
Administrator Armstrong, thank you for the question. We do have, it seems like once or twice a year, there's a little bit of spike in commitments of youth coming from the counties. And so that wait time in detention can sometimes go beyond the 30-day target. Youth in detention still have access to education and services. Our real goal is to get them with us as soon as possible so they can start their more intensive treatment. One of the things we did out of the 2017 session was to enact juvenile justice reform. And what we see in the last year is real implementation of a validated risk and needs assessment, the youth level of service. So every youth now in the juvenile justice system is getting that validated risk and needs assessment, and it's empowering our local probation departments and the Division of Child and Family Services to make sure that the services are really matching the needs of the youth that come before them. It's not, a hunch or a best guess. It breaks out different domains, and we're able to plug in services that are really needed. So our hope with that is that some of the low and medium risk youth that have traditionally come to the DCFS for correctional care are able to be preserved in the community and receive services appropriate to their needs in the community. It's still, we have about 6 months of data in terms of the makeup of our facilities, and there are very few low-risk youth now, a bigger chunk of those medium-risk youth. And so one of the reasons that we, in our approach to the juvenile justice cuts, preserved community corrections block grants, which go to county probation departments to help them with prevention, and preserved youth parole, which really tackles that aftercare to make sure that once we have a youth at our facility and they re-enter the community, that they don't return or escalate up to the adult corrections center. Is that we wanted to preserve those key community supports for those youth, understanding that they're for the highest risk youth, that time in correctional care can be incredibly helpful. For those low and medium risk youth, there may be no actual net benefit to meeting their needs.
Thank you. And a quick follow-up too. I understand that we're doing everything that we can to make sure that we're getting them into these facilities as quickly as possible. I just have concerns specifically with schools changing and shifting more towards distance learning. We tend to see spikes for student populations and for youth during breaks. And so I think that that's something that we need to account and plan for, because the spikes that we generally see during summer or perhaps winter break are possibly going to occur more often. Additionally, I think that it's important that we have a plan in place for these individuals so that they're not just held at detention centers where they're not receiving the quality of services that they need. We need to also consider ensuring that the detention facilities aren't just certifying more youth. So I hope that that's a discussion that's being had rather quickly here.
Assemblywoman Douglas Boone.
Thank you, Speaker. To my colleague, Assemblywoman Torres's point, I was wondering, you stated that you are working closely with the juvenile probation centers. I was wondering, with the success of programs like the Harbor and with them opening up 2 other facilities, I was wondering how close do you work with them to make sure that those lower level offense students that you just spoke about get the resources that they need first through programs like the Harbor before they come to you? Thank you.
For the record, Richard Whitley, Director for Health and Human Services. We're very supportive of the Harbor, and in fact, I'm grateful for your question. I think even Assemblyman Yeager's question earlier touched on family resource centers. More than ever, we're reliant on resource centers like the Harbor. Clark County Social Services has plans to extend that with mobile family resource centers. We're certainly looking at CARES funding to help support some of that now with increased needs. But you raise I think an important point that we didn't really talk about a lot today, and that is the services that are provided in the community that are not always coordinated, but they're essential and provided by nonprofits. And those services can keep at-risk youth, at-risk families, at-risk adults in a level of care that is most independent and avoid criminal justice involvement. So we are very supportive of those. And when we have grant opportunities, we direct that way. We've embedded our own staff, welfare eligibility workers, some of our behavioral health staff. We're working with the family resource centers as well as the model with the Harbor to only expand off of that in these times where the resources are not provided by government. They're really provided by nonprofits in the community that fill gaps on things that aren't reimbursed for. So we're committed to that, and we'll focus on it as we go forward with the additional funding opportunities that come out of this crisis.
Follow up. What are the staffing requirements, since most professional and juvenile justice and social workers and therapeutic educational support for our young people? What are your requirements trying to fill the positions that were vacant? Was that an issue, trying to find people to actually fill those positions that meet those qualifications? Thank you.
This is Administrator Armstrong. The issue of recruiting and retaining staff for juvenile correctional facilities is a hot topic, not just for us here in Nevada, but across the country, especially as our juvenile justice system continues to move away from a punitive system into a true therapeutic and rehabilitative system. And so the National Organization for Correctional Administrators has put out a toolkit that we've been working through to hire, not just more staff, but the right staff to really help these vulnerable kids take a different path than they were on before. And so our qualifications for the group supervisor series, are pretty minimal at the start and go up in terms of experience as you work your way up through the system. There are specific, background checks and training requirements that are required by statute and Nevada Administrative Code. And so there has to be some experience in working with kids before you come to us. So, that certainly is, some of the struggle. Some of it is making sure that we are actually doing the right outreach and recruitment strategies to bring the right folks in. We can tell pretty quickly if we have a staff member who this is not the right fit for and they don't stay with us long. So that can be another source of, of those departures and vacancy rates.
Any other questions? Seeing none. Director Whitley, is this, I know it kind of went out of order from our order. Is this the last of your presentation? Oh,
Yes, it is.
okay, I think I have at least one more question. Assemblyman Edwards.
Thank you, Mr. Chair. I've actually waited to make this suggestion till after I heard both education and HHS. For the past day and a half, I've kind of listened to everybody anguish over these cuts because they're pretty devastating. We're about to lose hundreds of millions of dollars of programs and services that are needed. I have a solution that will restore about $300 million. It will eliminate just about all of the education cuts, with the exception of Read by 3 and the new funding formula. It will also put $70 million more into Medicaid, which, as we heard, we desperately need, and that will yield us an additional $175 million. So we can address the issues of the autistic, the mental health, and so on. There's no new taxes, there's no increases to taxes, and it pretty much helps everyone that we want to help, the low income, the minorities, those who need these services. So how does it work? Well, we spend $10,000 per student per year. 18,000 students cost $180 million. If we were to offer a cohort of those 18,000 students an average of a $3,000 opportunity grant, we would actually only cost $54 million and save us $126. $70 million could go to HHS for Medicaid and yield us that $175. $55 could go to education and save just about every one of the programs that we're about to cut. Really math. It'll save us $300 million this fiscal year, $600 million in the next biennium. That's some serious money. I think the recommendations has some great potential, absolute viability. And as you know, the governor was looking for a Republican to step up with a solution to these problems.
Assemblyman Edwards, I'm going to have to interrupt you. We are in the committee of the whole with an agenda and a presenter on a specific topic. We are not on the floor of the assembly. We're in the committee of the whole. So what would save time is for members that have ideas to have provided those ideas before the second day of a special session in the middle of a committee of the whole presentation from the Department of Health and Human Services. So I'm going to redirect you because I don't think this is a question pertinent to this witness. And we will reconvene as an assembly. And if you want to use your 2 minutes when we do that, then you certainly may be able to do that. But if we are actually trying to accomplish something, I think that we should provide that to the folks that can implement it instead of grandstanding on the floor of the committee of the whole.
Sorry, Mr. Speaker, not meant to grandstanding. I just didn't know the perfect timing to say this.
We are taking questions right now with respect to the Department of Health and Human Services. Do we have any other questions with respect to the presenter that we have before us right now? Director Whitley, I'll ask you, and this may be an unfair question and an overgeneralization, but clearly we have spent a lot of time struggling with these decisions, and clearly you have spent a lot of time trying to come up with cuts based on this pandemic and the economic crisis we find ourselves in. On an elementary level, though, if frequently when we have department and agency cuts, there are tiers of cuts and levels of cuts that do harm. Could you identify or could you state if we were able to find revenue specific to DHHS, what level of revenue would it take to have a meaningful impact on the cuts that we've discussed today? And I believe that you started this off talking about the priorities being in direct services with an eye towards assistance from the CARES Act. So with an eye towards prioritizing those direct services, is there an amount that would have a meaningful impact in the delivery of those direct services so that if we are ever able to have a conversation about shifting resources or revenue, that we can point to something specific to minimize the impact within DHHS? Is there an amount, or could you put some thought into a tier that would minimize across the board the harm that may be caused with these cuts.
Sure. For the record, Richard Whitley, I would focus the priority to Medicaid and the prevention of reductions and eliminations in Medicaid, because it's a population-based approach to our highest risk residents in our state. And so I would prioritize the Medicaid reductions. And if you want me to provide you, tonight, a listing of those and the dollar amounts in some order, I will make an attempt at it. But we don't invest adequately in health care. So these reductions, they're all essential services, but I would do my best job for you to provide you if there are things. I think looking at what is available and what we could leverage with the federal funding is a big factor in it as well. I'm sorry.
I'm sensitive to the fact that this probably makes you feel like you're having to pick a favorite child. I think it would be helpful if you could give us an amount, a package that if we could come up with resources to do it would minimize the damage of these cuts. And I realize that's a difficult thing to do, but to the extent that you could give us at least some type of package that would be a level up from what we have now so that we could at least pitch that and have a conversation about that, I think that would be helpful.
I will do that.
Thank you. Assemblywoman Carlton.
And thank you, Mr. Chairman. I was going to ask a question somewhat along the same line. I think you've been sitting in committee with me too long, so you better be careful. You may want to switch committees next session. So I have a listing, an attachment that goes along with some of the things that we discussed today, and I just thought it would be good to put some of these numbers on the record, that the general fund reductions in this conversation today would be approximately 140 million, and the total reductions, when you include county money, federal money, and other grants that are included, means that the state is losing 699 million. So if we're starting to look for where we can put some money in to leverage more federal money to get that 3-to-1 buyback, I think one of the numbers you might be looking at, and Mr. Whitley, I'd be happy to have your folks correct me, but it would be close to $140 million if you wanted 100% of this. So anything up and around to about that point is the dollar amount that general fund impact is on the citizens of the state.
For the record, Richard Whitley, correct.
Any other questions? Let me look at the email. All right, I see no further questions. Thank you all for your patience and for sticking around to provide us with a thorough presentation, Director Whitley and your staff. I appreciate you, and if you could provide again that list within Medicaid and also prioritize within that list to the extent that you can, I think it could prove helpful for the body.
Thank you.
Thank you. Assemblywoman Benitez-Thompson.
Yes, Mr. Speaker, are you ready for us to, a motion to report back to Assembly?
I think we have one more. We still have CIP.
Oh, yeah, we're still here. Thank you.
Okay, so if BPS can indicate whether or not we have folks from CIP ready, then we can move on.
Yes, Mr. Speaker.
Yes?
First caller. I'm sorry.
I'm sorry, do we have someone from CIP?
Yes, Mr. Speaker, this is CPS. Ward Patrick is connected, but he is not unmuting his camera.
Mr. Chairman, sorry. Ward Patrick here for the record.
Good afternoon. Are we only telephonic or do we have video? Oh, there we go.
I appreciate it. Thank you for your patience.
Thank you. If, Mr. Patrick, if you could go proceed and provide your presentation, and then we will get to questions of the body.
Thank you, Mr. Chairman, and good evening. Good afternoon. For the record, my name is Ward Patrick, Administrator for the State Public Works Division. Available for testimony is Kent Lefevre, Deputy Administrator, and joining us from the Governor's Finance Office is Stephanie Greenemeyer, Deputy Director. When the COVID-19 pandemic began, the division was asked by the Governor's Finance Office to look at general fund opportunities anywhere in the CIP. To begin the presentation, I'd like to highlight some statistics that will frame the presentation. First, in March of 2020, there were 192 authorized and active CIP projects, predominantly from the 2017 and 2019 CIP bills. The authorized funding is summarized as follows. Key number here is general funds, 156 million of them, 341 million of general obligation bonds, and the balance of the authorized CIP is in other money, 284, for a total authorization of 780 million. At that time, the unspent portion of the 156 million of general funds was approximately $100 million. Considering these items, the recent IFC actions, considering completed project general fund reversions that were recent, and this item today, approximately $100 million of general funds will have been extracted from the active CIP projects. So basically all of the unspent money has been extracted. This proposal has been completed thoroughly, strategically, and in close communication with the Governor's Finance Office. The Treasurer's Office was involved, their statutes were reviewed, and bond counsel was consulted. There were many challenges during the early stages of the pandemic, which for the State Public Works Division included construction season kicking off in Northern Nevada, the determination that construction was essential, and putting many contracts on hold to enable this proposal to be made, of which the construction contract holds have been released and are proceeding, and projects not subject to this proposal are also proceeding. All general funds in the capital improvement program were considered to be either reverted or swapped with general funds, general obligation bonds. The results of all hands on deck since March 20 yielded the following two handouts before you today. They're entitled Capital Improvement Program Fiscal Year 21, the first one being General Fund Budget Reductions and General Obligation Bond Budget Reductions. These are both landscape formatted documents. The general fund document has 3 pages. The bond document is 1 page long. These are both sorted in project number order for ease of reference. The columns on the general fund budget reduction handout are project number, agency, project description, general fund reduction, recommendation, and clarifications. The general obligation bond budget reductions handout offers more information on donor projects. There are 35 CIP projects that have general fund budget reductions. The Governor recommends approval of this proposal to make available $72,599,117.45 of general funds for purposes other than the CIP. Many of the items within this recommendation are affected by the goal of keeping institutions and government functioning. Without building systems functioning, prisons would be without physical necessities, and key government buildings could be without heat, light, air conditioning, and other building system functionalities. Our division has a board, and the board has approved priorities for funding projects. And these priorities were utilized. Keeping existing facilities operating has been a long-standing goal of our board, with institutions and offices of governance being the highest priority. This is also known as taking care of what we have. But in this case, the priorities were used in reverse, not to fund the CIP, but to remove general funds. There were also 2 maintenance projects that were short of funds, and so we bid these and could not award them. And they're listed in the division's project exception report. It's provided monthly. These are recommended to be referred to the 2021 CIP review process. This will be covered in more detail later in the presentation. Almost every department contributed to the solution of contributing either general fund or general obligation bond reductions. This will be demonstrated as we go through the presentation. Highlights from the first page of the general fund handout begin with canceled general funded projects. The first group of items to highlight are those shaded projects that are to be canceled. On page 1, the UNLV Engineering Building, CIP project number 19C30 is listed. On page 2, a corrections project, 19M24, surveillance system replacements, Casa Grande transitional housing. A health and human services project, 19M25, install panic alarm at Deanie Townsend Hospital. A veteran services project, 19M27, pavilion renovation at Northern Nevada Memorial Cemetery. And near the bottom of the page, another corrections CIP, 19M48, install recreation yard fencing at Southern Desert Correctional Center and High Desert State Prison. There are no canceled projects on page 3. This whole process was an extreme challenge. As you know, the capital improvement program consists of much needed projects. The maintenance projects are repairing and replacing failed, partially failed, or failing systems. It is difficult to recommend canceling any of these projects. We've just covered cancellations regarding scope reductions. Page 1 and 2 include no scope reductions. On page 3, 6 of the 10 projects have scope reductions recommended. 2 from the Department of Conservation and Natural Resources, 2 from Department of Administration, and 2 from Nevada System of Higher Education. These have those scope reductions. All of these projects are important to the state of Nevada. Project 19M53, park facilities and ADA upgrades at Fort Churchill State Park. Scope will be reduced from through construction to through full design. Full design is also known as construction documents. I would also draw your attention to a minor error for project 19M59. Please consider the entry under the recommendations column to be deleted and rely on the clarification section that this project will be swapped, as this project will not have any scope reduction, but will go through this a swapping of removing the general fund and putting in bond. The next project is a key project for the state as well. Project 19P01, Advanced Planning Grant Sawyer Office Building Remodel. This will be reduced from full design to through schematic design. As you're aware, the Grant Sawyer Office Building has not been receiving needed upgrade and rehabilitation funding for all the many building systems. This 224,000 square foot state office building was opened in January 1995, and the building systems are mostly original. It is true that the central plant has been upgraded and the roofing has been replaced. The balance of the systems, including heating, ventilation, and air conditioning, plumbing, electrical, door access controls, architectural finishes, and other systems are in poor condition, and the building should be remodeled. Decreasing the scope of this project keeps the option open to fund the balance of the design along with construction next session. But it is likely that this reduction of scope will delay the corrective measures in this building to fund them in the 23 session. This would effectively slide the schedule of the remodel or remodel completion another 18 months. So this would effectively move the remodel out and reopening of the building from 2025 till late 2026. Project 19P08, Advanced Planning, Heavy Equipment Shop and Renovation ELCO, will be reduced from full design through schematic design. Project 19P70, Planning Great Basin College Welding Lab Expansion ELCO, will be reduced from through full design to through schematic design. Project 19P71, Planning Western Nevada College Marlette Hall refurbishment in Carson City, will be reduced from through full design to through schematic design. And finally, in this category, Project 19SO5, Statewide Paving Program. This will be reduced from maintaining paving on 7 sites down to 3 sites. The 3 sites are 2 ELCO projects and the Carson City Stewart Street Parking Lot Rehabilitation Project. These have been bid and awarded, and the contracts are executed. You have the 2 documents in front of you. There was a third companion spreadsheet that's been given to legislative staff that has far more detail on the fiscal changes and the scope reduction. The remaining projects on this list are proposed to continue with general obligation bonds, replacing the general funds, which is being referred to as general funds are being swapped with general obligation bonds. I have a clarifying comment on the swapped projects with regards to project 17M01, which is on top on page 1, Deferred Maintenance Nevada System of Higher Education. There's a reference to $1,319,778 of general funds that was approved as part of the fiscal year 2020 reductions approved at the June 25th meeting of the IFC. Therefore, this proposal for consideration is limited to the $214,271 swap of general funds with bond funds from Project 17M70. Now I'd like to draw your attention to the 1-page landscape handout referring to general obligation bond budget reductions. This effort makes $38,965,600.35 in bond money available to swap for general funds. The column headings are authorizing legislative year and bill number, department or agency, project number, project description, proposal description, and recommended reduction, also known as donor amount. Projects recommended to be canceled include these 4. Project 17M66, plumbing fixture water control renovations, housing unit 1 through 4 at Southern Desert Correctional Center. Project 19C16, that project will be reduced from through construction to through full design. Project 19C16, renovation of Collection Storage Building 19, Stewart facility, will be reduced from through construction to a full cancellation. Project 19M36, the Visitor Center renovations of Valley of Fire State Park, will be reduced from through construction to full cancellation. Project 19M50, Comfort Station Replacement, Valley Fire State Park, will be reduced from through construction to, again, to full cancellation. That ends the canceled section. Now there's a few projects that are listed as scope reductions. There's 5 projects. Project 17M70 will be reduced from through construction to through full design. That was project exterior renovation of the Nevada State Capitol and Annex building. Project 19M14, construct water wells and water systems at various fish hatchery sites, will be reduced from through construction to through full design. Project 19M20, replace flooring Caliente Youth Center multi-purpose building, will be reduced from through construction to through full design. Project 19M30, central plant renovation at Attorney General's office building, will be reduced from through construction to through full design. The final one in this category is Project 19S01 statewide roofing program, which will be reduced. Here, this means the Lovelock Correctional Center Housing Unit 1 and 2 and the Carson City Railroad Museum 2 buildings will be completed as funding is available. So in the statewide programs, we have priority 1 projects listed, which are a commitment to get those projects done within the available funds, and priority 2 projects that if funding is available, we would implement those projects based on savings from priority 1 projects. And so that procedure would be followed. Essentially, these 2 projects would be moved to the priority 2 category. There are 4 projects that have been identified where general obligation bond savings is recommended to be removed from the project, and the authorized and required scope will still be completed. So this is savings only, no modification to scope. These projects are located approximately halfway down the page, starting with project 17S01 statewide roofing program. Due to cost containment efforts, there are savings here. 19C02 Readiness Center completion. Based on the actual intermittent use of the facility by the National Guard, the Division of Environmental Protection reduced the size of the septic tanks and tile field necessary to serve what is called the Speedway Readiness Center. 19C19 Education and Academic Building for Nevada State College has savings, and this is due to favorable subcontractor bids. Project 19C28 Health Sciences Building, College of Southern Nevada, also benefited from favorable contractor bids. The remaining 10 projects are listed as completed. These projects at the time of the evaluation were going through final closeout and payment processes. These projects are planned to remain active after the specified bond amounts are transferred. Projects that are recommended to be canceled or have scope reductions will be considered in the 2021 capital improvement program process. That concludes the presentation on the recommended capital improvement program budget reductions. Thank you.
Thank you. I'll first go to Assemblywoman Swain.
Thank you, Mr. Speaker, and thank you, Mr. Patrick. I think I have a first kind of general question that might be helpful for the body. You were using the terms, you were talking about instead of going through a full design, you go through to schematic design. I think it might be helpful to just kind of lay out that progression from schematic design to full design to construction. Just it helps kind of frame where those stopping points are. And then I have a question after that.
I appreciate that. So there's basically 3 levels of design that we go through. Schematic design, which is approximately 15 to 20% of the work. Then design development adds another 40% to that completion. And then the balance would be construction documents. And so combined, those three elements would be considered the full design.
Thank you. That's very helpful. And then I have just a quick question on the Grant Sawyer building. I'll say being delayed 18 months doesn't sound terrible in the whole scope of that big project. It will be at some point. Will current office space remain usable? What is there? Will we still be able to have offices in there with this delay?
So many of the building systems are at or have exceeded their useful life. So we're running on borrowed time on many of the systems. Prior estimates that we've been looking at here, for instance, the ventilation system, just the units on the roof, the air handlers on the roof, it's expected to only do that portion of this project would be approximately $10 million. And to give an example of the useful life, oftentimes, and you'll see as part of the money committees, that these air handler units are being replaced on pretty much all buildings unilaterally in the 20 to 25 year time frame. And so the Sawyer building was opened in 1995. So those buildings are at the outer edge of that time frame now. I would also point out that there was a time when there were waste sewer issues in the building. And if anybody was in the building approximately a year and a half ago, we had to cut the floor open near the cafeteria area and replace approximately 100 feet of the main trunk line leaving the building. And so the conditions throughout the building, so that was the very worst where it was plugged at that time, but it would be very disruptive to replace the piping elsewhere in the building, because it would be down the common areas and central part of the building if there were, failures anywhere else underneath the building slab. So we certainly have been, Public Works with Buildings and Grounds together have been stepping up our game performing maintenance in the building, and so we're confident, not just hoping, that we should be able to handle these items as things come up. So if this is funded in the 21 session, which I discussed previously, construction might start around January to March of 22. But if it's obviously if it's delayed 2 more years, it would be January of 24. So
thank you, Mr. Patrick. So it seems as though we'll be able to keep folks in the building at least for some period of time, with maybe a few hiccups here and there. I have a quick other question for you for statewide roofing, if I may, Mr. Chair. So I know that means that some of the projects will be put on hold, and if you could succinctly just let me know if you think that's going to pose any issues for building integrity until the roofing projects can be completed. We know that the roof is probably the most important part of a building for keeping it all nice and tight. And if you think there'll be any additional costs that will incur to address kind of emergency costs. And given the time, if you can answer succinctly, thank you.
Certainly we'll do that. We have emergency funding within the project to cover leaks that due to projects that were on hold. And I would also point out that in recent months, bids have been coming in well in that area. So it's possible this reduction of approximately $300,000 to $400,000 out of that statewide program will have no effect.
Thank you.
Assemblywoman Titus.
Thank you, Mr. Chair, and thank you for your presentation. I too, like my colleague who loves history and buildings from the South, had concerns about the preservation of some of these buildings, and if we delay some of these improvements or necessary interventions will we be harming the buildings in the long run? So thank you for that clarification. I have a question regarding the capital improvement projects on your general obligation bond budget reduction form, and you have several there that the project has been closed, and then you say closed project, completed project. So under those 6 or 8, however many there are, I just want a clarification that the projects have been completed, and what we're seeing is then funds that were left over from the bonds that were already sent out or released?
That is exactly correct.
Okay, and then are there not restrictions on those bonds? When you send out a project and you release bonds, the bonds are purchased, if there's money left over from the total of the bonds, you can then transfer them somewhere else?
Yes, within the CIP bill, that's allowed. And I would point out that these are all compliant with bond council's requirements.
I guess I just want to compliment you that you were able to come in on this many projects with that much bonding capacity still available. But if we roll those bonds over, will that then affect future bonding capacity?
It's true that if the general fund were to remain where it is, these bond savings would go into the 21 CIP.
So we could roll them over and use them in the future, but we'll roll them over and use them now. Is that what you're saying?
That is correct.
Okay, thank you for the clarification. Thank you, Mr. Chair.
Thank you. Assemblyman Fumo?
Thank you, Mr. Chair. Mine is more of a comment rather than a question based on one of the projects. And I know everything you've done has been very, very tough, and I appreciate the presentation. But the UNLV Advanced Engineering Building has an impact for the state. You know, oftentimes Nevada is criticized as being a one-industry state. And this building, the Building of Engineering, had the impact to bring in and keep the brain trust here in Nevada. With the planning complete and the bonding in place, I just hope the legislature keeps this in mind when it places this project back on the top of the list when the funding does become available, because I think it's very important for the future. Thank you, Mr. Chair.
Thank you. Assemblywoman Cohen?
Thank you, Mr. Chair. I want to ask about on page 3, the park facilities maintenance and ADA upgrades at Fort Churchill State Park. Are we going to be out of compliance with the ADA if this doesn't go forward timely? What are we doing to protect making sure that we're in compliance with ADA?
Yes, thank you for the question, Ward Patrick, for the record. So at this site, the ADA component of this is more displaced sidewalks. And so that is something that will be able to be handled by the Division of State Park.
Okay, I'm sorry, I didn't understand.
Well, the predominance of the work in this project is the mechanical and electrical systems in this historic building. And so there's minor ADA items that need to be corrected. And so that could be managed by the Division of State Parks. Also, we have emergency funding in the statewide program for ADA that if there were pronounced problems, they could be addressed with that funding as well.
Okay, now I understand. Thank you very much. Thank you, Chair.
Thank you. Assemblyman Ellison?
Thank you, Mr. Chair. Hey, you mentioned real quick about the Stewart camp. Was that the Stewart prison or is that the Stewart Indian Colony remodel project? And was that totally not going to be funded? Was it going to be tore down or just left the way it was? If you could answer that.
Thank you. The project that we're referring to is a project to remodel Building 19 to allow it to be used for storage of exhibits for the Indian School Cultural Center. So no, it's not at the conservation camp. It is at it's in support of the Stewart Indian School Cultural Center.
Thank you.
Further questions? Let's check the email.
If I may, Mr. Chairman.
Please.
Further that answer, that is a historic building. There's no intention of tearing it down. I think that was part of the original question. Thank you.
Thank you. No other questions? Madam Majority Leader, can you get us a recess? Just 1 minute. 1 minute recess.
Mr. Speaker, 1 minute recess.
Committee will come back to order. We have completed the informational items for today's agenda, and when BPS is ready, we are ready to go to public comment for the Committee of the Whole.
Ready, Mr. Speaker, for public comment. Caller with the last three digits of 100. Please pronounce and spell your name slowly for the record. You have 2 minutes. You are muted. Maybe.
Hello, this is Rob Richardson, ROBRICHARDSON, and I am the president of the Nevada Ambulance Association. First, I'd like to thank you for this opportunity to share a few comments on behalf of the Nevada Ambulance Association that represents the majority of the private ground and air transport services for the state of Nevada. We appreciate how difficult it is to balance a budget during such unprecedented times that has resulted in such a devastating budget deficit. I'd like to share our concerns with reducing Medicaid reimbursement for the ground and air ambulance transport services. Ambulance services are a safety net provider within the state. This means that when all else fails, our emergency agencies respond and transport patients in coordination with our municipal fire department partners. As a good private partner, we sign agreements to respond and transport patients who are in need of ambulance transports, regardless of the patient's health insurance or ability to pay. In a time when there is increased demand for medical care, those who are receiving Medicaid benefits depend on those services for life-saving transports. Currently, Nevada's Medicaid reimbursement is one of the lowest in the nation. Unfortunately, with each transport provided, the current reimbursement fails to cover the cost. Having a further reduction in reimbursement will widen the financial losses for all agencies. If the loss becomes too great, we will need to make operational decisions that could potentially reduce coverage in their respective areas. This is not ideal in even the most stable of times. Our experience is that when there is a loss of medical access, Medicaid patients will begin to use ambulance services and emergency rooms as their primary health care providers, which in turn further extend the financial loss and a potential reduction in resources. Again, we understand that these are unprecedented times, and we recognize that you will need to make cuts where you feel it is best to cut. I ask that you please consider carving out emergency transport ambulance services, or at a minimum, as new funds become available, that you would consider making emergency services whole as soon as possible. Thank you for your time.
Thank you.
Taking the next caller. Caller with the last three digits of 918. Please slowly pronounce and spell both your first and last name for the record. Have 2 minutes. You are now unmuted and may begin.
Thank you. My name is Leanne McAllister, LEANN, capital ALLISTER, and I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. Thank you for prioritizing the health and welfare of children in Nevada as you face economic and public health threats from the coronavirus pandemic. The Nevada AAP urges you to consider revenue-boosting measures that also improve public health. The American Academy of Pediatrics has long supported taxes on sugary drinks and tobacco products, as these taxes both reduce harm and increase funding for other public health concerns. One of our main concerns is the reduction in the already inadequate funding for vaccinations and other low-cost preventative care, critical for avoiding future public health crises. Decades of research has demonstrated that increasing the generosity of Medicaid by itself is enough to improve access to care and the health of low-income populations. The Nevada AAP currently has 277 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. My members are available to the Nevada Legislature to answer any questions that you have about health policy that impacts children, adolescents, and young adults in Nevada. Thank you.
Thank you very much.
Next caller, caller with the last 3 digits of 179. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes and may begin now. Okay, taking the next caller. For caller with the last 3 digits of 179. You are now unmuted. Next caller with the last 3 digits of 301. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted. May begin. Caller with the last 3 digits of 179. You are now unmuted. Next caller, caller with the last 3 digits of 301. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Good afternoon. My name is Alan Feldman, ALANFELDMAN, and I serve as chair of the State Advisory Committee on Problem Gambling, and I've also spent 30 years in the gaming industry here in Nevada. The presentation by DHHS concerning cuts to the Problem Gambling Fund was extremely troubling. DHHS might have sought the input of the committee before making this recommendation. While we knew cuts were coming, the DHHS proposal to cut almost 80% of the funds is massively disproportionate, only leaving $600,000 for services. The state is already the payer of last resort. No state funds can be distributed unless the treatment provider has first exhausted any private insurance or Medicaid reimbursements. However, private insurance often doesn't cover problem gambling treatment, and only a small number of patients qualify for Medicaid. But at the same time, the department is suggesting increasing billing to Medicaid. It recommended a stunning $140 million cut to Medicaid services in Nevada. So which is it? There's nowhere else to turn. Medicaid as a source of additional funds is a dead end, and both it and insurance are already factored into the current funds allocated for treatment services and couldn't possibly fill the gap. The department's recommendation of an 80% cut to the budget is not justifiable, and the recommended fixes are not viable. The disparity in cuts was best displayed this afternoon by Director Whitley himself, who earlier today proposed a cut to the Fund for Healthy Nevada. But later, when asked about the effect on current grantees, admitted that no cuts were actually being made, but the cut was just sweeping reserve funds that were unobligated. So those grantees are still getting 100% of funding, while problem gambling funding is being cut by almost 80%. Then later, when questioned about the justification for such a draconian cut, the department said it was to avoid cuts to mental health programs. This is absurd. This is a cut to mental health programs. Cutting the $2 million budget is totally understandable, and a reduction of 20 to 30% has been anticipated. We appreciate anything you might do to support a reasonable budget cut to this vital program. Thank you.
Thank you, caller. Caller with the last 3 digits of 478. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hi, my first name is Adam, A-D-A-M, and last name is Barrington, B-A-R-R-I-N-G-T-O-N. I am a proud state worker here in Nevada and a proud member of AFSCME Local 4041. And I would just like to point out that workers have been consistently expected to make tremendous sacrifices while the elite and massive corporations take advantage of our loose tax laws, and indeed they get direct subsidies that often come straight out of the wallets of the taxpayers. So we privatize profits to socialize costs. In Nevada, corporations have gotten over $1 billion in subsidies, Tesla alone, hundreds of millions of dollars going to other corporations. And on top of this, they pay such low wages that we have to subsidize those low wages with tax dollars that go to programs like Medicaid. This is morally outrageous and unacceptable, and the very idea that we would consider cutting education and cutting healthcare in the middle of a pandemic, it's like I said, it's morally outrageous and it's unacceptable. We know where the money is, including the mining industry. All this stuff has been said before. The Nevada legislature just really needs to consider the fact that people are desperate right now, and if you're going to start cutting wages of state workers by 5%, which is what a furlough amounts to. That's what we're looking at. $70 million from education and healthcare. How can we do that? It's an outrage, and this is a moral question. We know where the money is. I hope you strongly consider looking to these massive corporations and the wealthy elites, as well as the federal government, who they consistently bail out massive corporations with trillions of dollars. They can do the same for state and local governments. Thank you.
Thank you, caller. Caller with the last 3 digits of 404. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Becky Harris, Beckyharris. Good evening, Speaker Frierson, Majority Leader Benitez Thompson, and members of the Assembly. I want to thank you for your service to our state and share my thoughts on problem gambling. According to the National Council on Problem Gambling, there are an estimated 61,000 adult Nevadans with gambling problems. The estimated annual society cost to Nevada families and communities from gambling-related bankruptcy, divorce, crime, and job loss is about $38.5 million, mainly in criminal justice and healthcare costs. And this will only be amplified by the stress of the pandemic that has hit Nevada and the rest of the country and the world. In the past year, states that have traditionally neglected funding or had severely underfunded problem gambling services have begun to invest heavily in problem gambling. Some of these states include New Hampshire, the District of Columbia, which isn't really a state, Illinois, Tennessee, Virginia, and Michigan. For every dollar made in preventing and treating gambling addiction, there is a $2 savings in cost for services and other costs that are borne by government. The ravages of COVID-19 have placed you in an untenable circumstance as you come together with your colleagues to determine how to help the state of Nevada move forward. And I know resources are limited and the demands are overwhelming. But to consider the necessities, I urge you to resist cutting the funding for problem gambling. There are so many among us who are vulnerable and struggling. One of the best investments that can be made in our state at this difficult time is to ensure that those who are vulnerable among us have access to care, treatment, and mental health programs for addiction, specifically problem gambling, especially since the return on investment in prevention and treatment is 2 to 1. It's a good way to spend dollars. As you may be aware, in 1999, the Gaming Control Board issued regulations related to problem gambling. As a result, restricted and non-restricted gaming licensees are required to post or provide in conspicuous places written materials concerning the nature and symptoms of problem gambling, as well as resources. Gambling licensees are also required to train their employees about such concerns. And then there's discipline if those licensees fail to provide the necessary training or program.
Ma'am, could you
funding
wind
for
down?
problem gambling in Nevada, yes. If funding for problem gambling in Nevada is cut by 75%, I fear that those seeking help for gambling addiction and who are relying on those materials posted at gaming establishments will discover that rather than getting resources, they're going to be chasing an illusion. Thank you so much for letting me share my thoughts.
Thank you very much.
The next caller with the last 3 digits of 242. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin. Caller with the last 3 digits of 242. You are now unmuted. Next caller with the last 3 digits of 441. Please state and spell your name for the record. You have 2 minutes and you are now unmuted.
William Ted Hartwell, Hartwell. Esteemed legislators, I'm calling to express my dismay at the proposed 80% cut to the state problem gambling fund. In a state such as Nevada, where gaming is the lifeblood of our economy, and where the state's one commission study, almost 20 years old now, shows that our citizens suffer from a problem gambling rate higher than in any other state, for an illness which has a higher suicide rate than any other mental illness, and with research in the field that shows that gaming industry employees often experience a higher prevalence rate of problem gambling than the general population, the proposed cuts as offered are unconscionable. I've been a faculty member of the Desert Research Institute since 1991. I'm a professional cellist and founding member of the Las Vegas Philharmonic. I've been a soccer and volleyball coach. But the accomplishment I'm most proud of in this world is to be able to say that I am a person in long-term recovery from a gambling problem. For me, that means I haven't felt the need to make a bet since September 14, 2007. Despite many attempts to stop gambling on my own, I nearly destroyed myself and my family before I was willing to admit I needed help. That help came in the form of professional treatment at the International Problem Gambling Center in Las Vegas. In 2007, I was one of the early benefactors of Nevada's Problem Gambling Fund. Without that service, I am uncertain where I would be today, or indeed whether or not I would even be alive. As a direct result of that treatment, I not only healed the personal and financial relationships I had damaged, but have since dedicated my life to the service to the state of Nevada on this issue. At DRI, I've conducted research and outreach on problem gambling in Nevada's tribal communities. At DRI, and as a musician with the Las Vegas Philharmonic, I have connected many colleagues in need of treatment or information to Nevada's problem gambling services. After many years of volunteering, I now consult to both the Nevada Council on Problem Gambling and the gaming industry. And finally, I'm honored to have served at the pleasure of 3 Nevada governors on the State Advisory Committee on Problem Gambling since 2012. None of these accomplishments would have occurred without the treatment I received through this problem gambling fund. Please ensure reduction in funding in the area of problem gambling is at worst no less than average budget reductions in other areas. COVID-19's financial and emotional impact has caused more Nevadans to be at risk of developing gambling problems than at any other time in recent history. Cutting the availability of these services will result in an increase of individuals who will ultimately be a much greater burden on Nevada's health services and justice systems, and those costs will greatly exceed the cost of having treated them for their gambling problems in the first place. It will cost some Nevadans their lives. I thank you most sincerely for your consideration.
Thank you, sir.
Caller with the last 3 digits of 771. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hi, this is Leslie Turner. Can you guys hear me?
Yes, ma'am.
Okay, good. Because I was on my phone, I was trying to get on my computer. Hello, this is Leslie Turner. I am a community organizer here in the South in Las Vegas with Plan Action and the Mass Liberation Project. I was just calling to put it on everyone's mind and heart that a part of this budget conversation, we should be talking about decarceration, we should be talking about money that can be saved by letting people in prison. So as we know from the Nevada Sentencing Commission hearings, that there are it's like 300 people who are waiting, who've already been given parole and they're still inside. So if we could work on getting those folks out, that could be a way to save money. And also the Board of Pardons also voted to start looking into getting people out amidst the pandemic, COVID-19. So also seeing what people are medically fragile who could go home or whose sentences are about to expire, things of that nature. Just really thinking about ways that we can get people home as a way to cut from the NDOC budget. I didn't see that mentioned in the budget document that was released to the media today. So I just wanted to put that out there. And also that like Black Lives Matter is a conversation that is also a budget conversation. It's not just a conversation to be set aside to have separately in a social justice theme now during the budget as well, especially in the midst of a pandemic, in the midst of an uprising. A lot of people are experiencing a new way of life that they've never had to live through before. And I think that we should be really imaginative and creative in finding solutions that that do not cause more harm. So that's pretty much all I wanted to say. Thank you.
Thank you very much.
Next caller with the last 3 digits of 242. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hello, this is Carol O'Hare, Carol, last name O''Hare. Thank you for the opportunity to comment today. I'm the Executive Director of the Nevada Council on Problem Gambling, and I have submitted written statement to both the members of the Senate and the Assembly, and I've listened to the department's presentation yesterday and today. I'm calling with my comment today out of my personal concern and dismay at what I'm hearing being presented. I am also a person in long-term recovery, and for 29 years, I have had the blessing of being able to be in recovery in Las Vegas as a problem gambler, which confuses a lot of people, but recovery is quite possible and actually even more possible in this community due to the extensive support system that we have, peer support. So I'm speaking on behalf of those hundreds and hundreds of people in Nevada who cannot put their name on public record because the stigma associated with this disorder is still so high that being in a position of authority, being in a position of respect, could be damaged by the mere acknowledgement that they're a person in recovery. So I have to react today as a person in recovery, and I find it shameful that I've listened to the department describe multiple programs in great detail with specific examples of the people they serve and the time they're spending talking to the providers and how they're going to fill these gaps when they make these cuts. And when they talk about the Problem Gambling Fund, it's crickets. They tell you their method was they didn't have any place else to cut, so they took the rest of what they had to take from the smallest fund and gave us the deepest 80% cut. That will decimate services, people will not get help, and these people have the highest suicide rate of any other group in mental health. I know I sound emotional, I am, because this is personal. And to not even hear the department describe the services, describe the people who are helped, and to not hear a single question from my elected leaders asking about the impact that it will have on these people. I was ashamed today. I've worked 25 years in public advocacy, and we are still a throwaway population who isn't even recognized to be included in direct services, which they said was the priority. And instead, we're the bottom of the food chain, and they've taken money simply because they needed to take it from somewhere. I hope that you will read all of the comments. I support every other comment that's been made on the phone, Mr. Hartwell, Becky Harris, Alan Feldman.
And we have,
I
ma'am,
hope
but
you will
we've gone to
remember
3 minutes if you could wind down.
Yes, thank you. I appreciate your consideration.
Next caller with the last 3 digits of 508. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hello, this is Dr. Bo Bernhard. Bo is B-O, Bernhard, B-E-R-N-H-A-R-D. I am the Executive Director of UNLV's International Gaming Institute, the world's largest and most respected academic institute studying the global gaming industry. I also hold the Philip G. Sautre Chair at the University of Nevada, Reno, which makes me the state's only dual campus full professor. More importantly than that, though, I'm a 5th-generation Nevadan, and going back 5 generations in this state, I want to continue to be proud, and that is why I'm speaking today on the problem gambling cuts. As the premier academic team in the world, each year at UNLV, we get called upon to advise governments on 6 continents that want to import our invention into their economy. With remarkable consistency, they have a single vital question that they ask when contemplating whether to allow Nevada's businesses to open in their backyards. And that question is this: what are you doing about problem gambling? For many years, Nevada's taken pride in its status as the, quote, gold standard in the global gaming industry. But if this legislature enacts a stunningly disproportionate 80% cut in problem gambling services with no cuts or 20% cuts elsewhere, we're ensuring that this reputation takes a major hit. The status as gold standard is not simply some trophy that we look upon proudly on some mantle. It is the very foundation of our state's economic development for tens of thousands of employees who rely on Nevada's gaming companies to sell their products and services around the world, with revenues coming back to a company with a Nevada address. I'm a professor, but I don't need to lecture this group, certainly, on the tax implications of those billions in revenues, as they are, of course, obvious to us all during this session. At an efficiency level, I'm also honored to lead a research team that examines how these state dollars are spent. I will summarize in 2 words: problem gambling treatment works. That's 4 words. Treatment works. Approximately 9 in 10 Nevadans who enter into these treatment facilities get better, as measured in workplace, family, and school improvement. These clinics are doing life-saving work, and without this funding, our state will lose these lifesavers. I ask you today, as leaders of this state, to maintain our status as the global capital and to make sure that none of us awaken tomorrow to headlines that read gaming capital slashes problem gambling funding. In closing, I would like to also bring everybody's attention to Jan Jones Blackhurst, the 2-term mayor of Las Vegas,
and ma'am,
longtime
sir,
business executive.
if you could wind down, we're well beyond the 2 minutes.
Yep. Yes. I would just call everybody's attention to her comments last night on the same issue, as she's unavailable today because of the merger with Eldorado. Thank you.
Thank you.
Next caller with the last 3 digits of 801. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Great. Hi. Thank you. My name is Mac Miller. First name Mac, M-A-C-K. Last name Miller, M-I-L-L-E-R. I'm a lifelong resident of Nevada, and I am calling to first commend Assemblyman Chris Edwards for his recommendation on how not to cut the budget. Unfortunately, a little too late, as the speaker mentioned, but I am specifically here, as I was yesterday, to say that I'm in opposition of any new taxes that are proposed. The budget cuts in the education system shouldn't be there, and the budget cuts in our healthcare system shouldn't be there. There are definitely other ways to find this money, but one of them is definitely not in the future of today or tomorrow, is in raising taxes. So thank you very much, and that is all.
Thank you, caller. Next caller with the last 3 digits of 451. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted. You may begin.
Brianne, Brianne, Dora, Doura. Good evening. My name is Brianne Dora. I'm the Legislative Director for the National Council on Problem Gambling. And on behalf of the National Council on Problem Gambling, the 7 million Americans, an estimated 61,000 adult Nevadans with gambling problems, I'd like you to make you aware of the significant concerns that we have about the proposed budget cuts being considered right now, inclusive of a 75% laceration to your problem gambling fund. When fully funded, your investment was still small, but a significance of $2.1 million. Today's proposal will bring that fund down to an alarming $600,000. Our national survey of problem gambling services found that in 2016, Nevada ranked 13th out of the 50 United States in terms of your per capita public investment in problem gambling services. These cuts today will drop Nevada to the bottom of the list. In just recent months, we've seen states all across this great nation making significant and powerful investments in problem gambling services. A cut of this magnitude by Nevada right now signals not only to your constituents, but the rest of the nation how little of a priority you consider this crucial public health issue is to you. The COVID pandemic has led to great financial and emotional distress, as well as job loss. 29% of Nevadans are currently unemployed, and these factors are all well associated with higher rates of gambling problems. Individual health will only be exacerbated by this time of uncertainty and stress. It's more important for Nevada to note that they cannot turn to the federal government to fill these gaps, as unlike substance abuse and other addictions, there's absolutely zero federal funding, support, and recognition for problem gambling. The federal government expects you as a state to fill these needs. The only way that your state will continue to maximize the benefits that you enjoy from legalized gaming is to minimize problem gambling. It's also abundantly clear that failing to invest in these services will not only cost lives and hurt families in Nevada, but will ultimately cost the state more financially.
And thank you, ma'am.
We
If you
urge
could
you
wind
to
down, we're down to 2
reinstate your
minutes.
funding for problem gambling in Nevada. Thank you for your time and the opportunity to submit my comments for the record.
Thank you.
Next caller with the last 3 digits of 080. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
My name is Susan Fisher, SUSANFISHER. I'm with McDonald Carano, and I'm speaking this afternoon on behalf of the Nevada State Society of Anesthesiologists. Mr. Chair, members of the Assembly Committee of the Whole, thank you for allowing me to speak this afternoon. The frustration and distress in the eyes of Dr. Whitley and his staff as they testified yesterday and today and having to make these drastic recommendations is palatable. I feel for them. I feel for you all. This is not easy. I have submitted a letter detailing comments, so I'm not going to read that all to you, but we do want to point out that we have been through this before. 10 years ago, the legislature cut Medicaid rates. While rates have gradually moved back up for many providers in the past 10 years, rates for anesthesiologists that were cut 40% 10 years ago have stayed flat all this time, and now they are to face another cut. That reduction in 2010 cost one particular anesthesia practice group in Southern Nevada over $6,750,000 in 1 year. A 6% reduction now will result in the loss of over $500,000 for this practice in the first year based on 2019 numbers. We know we already have narrow networks in Nevada. Recruitment and retention is already an issue. We have some very sick people in Nevada, and a few stats, 56% of patients between the age of 0 and 4 are Medicaid. 56% of congenital pediatric heart cases in Southern Nevada are Medicaid, and 100% of those cases are served by the anesthesiologist in that one practice group that I mentioned earlier. And I feel that with the impact dollars, we're stepping over $1 to pick up a quarter. We do provide some recommendations. We're not just saying don't do this. We know you have to do something. Consider making a 3% cut rather than 6%. Consider including a provision to apply the cut to the present budget year only. Consider including the Medicaid cuts among the governor's proposed recovery triggers so that when the economy improves, not if, when it improves, or when sufficient federal dollars arrive, the rates may immediately move back to current rates, which are already low. I thank you for your time and your service, and we wish you the best as you consider this heavy task. Thank you.
Next caller with the last 3 digits of 750. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hello, my name is Sally Bautista, SALLYBAUTISTA. And I am calling regarding the tax increase that is being proposed. I am completely against it. I've lived in Las Vegas for over, since 1972, from California. I've raised my children here and now my grandchild. I'm completely opposed to these taxes, especially in this time during this pandemic that we're all going through. Las Vegas is a city that relies on tourism. And there's so many people that have already lost their homes, losing their jobs, and now you want to raise taxes. It's ridiculous. People can't even afford to live right now. And you want to raise taxes. How can they even afford their medical bills or anything else? So the only thing that it looks like is like this town will become a ghost town. And it's a definite probability the way this is going. But again, thank you for your time, and that's all I would like to say. Goodbye.
Thank you, caller. The next caller with the last 3 digits of 117. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hi, my name is Michael Guss, spelled MICHAEL-GUSS. I called earlier today. I want to follow up on my comment. I found a report done for the 79th legislature of just the tax incentives that were given away by GOED and the Governor's Office of Energy in fiscal years 2015 and 2016. It was almost $3 billion as I added it up. Almost $3 billion. If we ask the people who received tax incentives to pay full tax for this fiscal year and then give them 2 years of the tax incentive on the back end, they're just refi their bonds. And we, won't really impact them, and we can have the revenue to address all these horrible cuts. Maybe not everything, but we can have a lot less cuts if we do that. And you know what? If a company doesn't want to chip in the middle of a pandemic, I'm not really sure as a Nevadan I want them here. And I would finally close by saying this. One of my mentors, when I worked really hard on an election when I was in college and he lost, came and said, there's worse things in life than losing an election. I've run for office and lost. There are worse things. The sun came up the next day. It is fine. I don't really think people 20 years from now are going to ask how long you served in the legislature. They're going to ask what you did at this moment, which is critical, because if we cut all these things now when people rely on it the most, when government is needed the most, people, their lives will be ruined. And so it's time to examine sources of revenue, and please start with tax incentives, because there's a way for that to be a tax cut. If you give them 2 years of incentives on the back end for the 1 year that they pay up front here, we solve part of the budget crisis without raising taxes. I really hope that you'll consider that. And thank you so much for your time, and best of luck making these tough decisions.
Thank you, caller. Next caller with the last three digits of 503. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Jesse. Jesse Wadhams, JESSEWADHAMS, on behalf of the Nevada Hospital Association. Nevada hospitals want to acknowledge the extraordinary challenges facing you, the DHHS, and the governor's office. This pandemic has created the economic circumstances putting you in this position, but it's also had a very negative impact on hospitals. Our hospitals responded for Nevadans. While people were afraid to seek care, we closed non-emergent surgeries, and we prepared our facilities and our capabilities for all seeking treatment. This created a significant financial hit during March, April, and May, driven by a 20% decrease in inpatient care, a 35% decrease in surgery, and a 30% decrease in emergency room visits. Hospital revenue decreased over 20%, while expenses only reduced by less than 1%. The proposed Medicaid cuts will further impact Nevada hospitals. We want you to have our perspective on as you make these decisions. While Medicaid rate cuts generate general fund savings of $65.3 million related to hospitals and providers, as you heard, these cuts are compounded. For example, the $33.4 million in general fund savings specific to hospitals will create an overall Medicaid payment cut of $120 million. Hospitals have historically funded a large portion of the cost of care for Medicaid patients. These additional cuts and Nevada's projected caseload growth is estimated to generate $628 million in uncompensated care for Nevada's Medicaid patients in our hospitals. Hospitals are projected to provide 49% of the total cost of care for Medicaid patients, more than 4 times the projected portion paid for by the state at 12%. Yes, hospitals do receive some supplemental payments to offset a portion of these uncompensated costs. Private hospitals in Nevada receive about $100 million in supplemental payments annually. But clearly, even this still leaves a significant uncompensated Medicaid cost borne by Nevada hospitals. Nevada's hospitals ask you to delay these cuts as long as possible, and if new money or federal relief does come, undo these cuts as fast as possible. We'll provide more information very soon. Thank you for your time and appreciate what you're doing.
Thank you, caller. Next caller with the last 3 digits of 142. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hi, my name is Kaylee Barnett. I'm a preschool teacher. I just wanted to say we need an income tax. We need a property tax restructure, capital gains taxes, and to tax mining and not the people, and not to cut taxes on education or health. Thank you.
Thank you, caller. Next caller with the last 3 digits of 529. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Good afternoon. My name is Heidi Parker, Heidiparker. I'm the Executive Director of Immunize Nevada, a nonprofit statewide coalition working to promote health and prevent disease. As repeatedly stated in earlier comments, we know many of these decisions will be difficult, and the proposed cuts will be painful as so many rely on these essential programs and services. We thank all of you and the teams at DHHS and DPPH, the Nevada Health Response, and our local health authorities that are working overtime to protect Nevadans during this pandemic crisis, working within an already underfunded healthcare and public health system. We have a specific and significant concern about any reductions to disease prevention funding and/or reductions which may impact access to care or disproportionately affect communities of color and those living below the poverty level, as routine vaccinations have dropped significantly since March, and funding cuts could exacerbate this already challenging situation facing both providers and patients. It's also crucial we avoid outbreaks of vaccine-preventable diseases during this public health crisis, especially as we are also headed into a potentially difficult influenza season, a concern referenced earlier during the DPVH presentation. As these budget issues are discussed, we also need to consider a long-term strategy for adequately funding public health as we continue to respond to this pandemic, future outbreaks, and plan for future COVID-19 vaccination efforts. We look forward to continuing to work with our state leaders and public health colleagues in addressing these critical needs for our state. Thank you.
Thank you, caller. Next caller with the last 3 digits of 582. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Jaron. Hi, my name is Jaron Hildebrand, Jaron, Hildebrand, Hildebrand, and I am the Executive Director of the Nevada State Medical Association. We are very concerned about the 6% cuts and the serious impact it will have to our healthcare providers. I have sent in a letter detailing our concerns, as well as 2 supporting documents, a survey that shows the hardships that our small private practices in Nevada has faced through this pandemic. The interest in our discussion today has to do with the 6.2 enhanced FMAP to Medicaid. We expect to receive this enhanced reimbursement rate through 2020, and we understand with the caseload and the utilization services analysis may make it possible to reduce the 6% cuts and possibly not cut our reimbursement rates at all. We stand ready to work with Medicaid, Governor Sisolak, you, the legislature, and to resolve any concerns and find solutions that we can all make Nevada better. Thank you so much.
Thank you, caller. Next caller with the last 3 digits of 695. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Good evening. This is Holly Wellborn, HOLLYWELBORN, Policy Director for the ACLU of Nevada. I appreciate the opportunity to testify this evening. We just have a couple of concerns on some budget items that I do not believe are going to be brought forth for testimony before the committee of the whole during your deliberations. Our first concern, we read an article in the Nevada Independent that suggested that the Nevada Department of Corrections intended to defer the return of 100 individuals currently incarcerated at the Seguro Correctional Center in Eloy, Arizona. That is a private prison owned by CoreCivic. We received some mixed information that the Nevada Department of Corrections intent was actually the opposite, and that their cuts were meant to expedite the return of these men to Nevada, which would be a very good development. It's imperative for this body to get clarification on this matter. Last session, we were proud to support Assemblywoman Monroe Moreno's bill, AB 183, which ended private prisons and sunsetted the contract with Seguro, which would which required that these men return to Nevada by 2022. If the intent is to delay returning these men back to Nevada, then it would violate Nevada law. Additionally, we've heard from many families who are affected by the fact that their family members have been moved out of state. We've sent letters to that effect, so it is deeply concerning to us. We hope to get clarification on this. Our other concern is on budget item 3740 from parole and probation, which is set to cut 21 positions, the Going Home Prepared program, and state aid for the cost of house arrest. Last session, the legislature made very clear that the public policy of the state is to reduce incarceration rates, thereby saving taxpayer dollars, reducing recidivism, and promoting public safety. We would like clarity on whether these cuts will further delay the release of the 300 individuals who were granted parole but are still living in Nevada prisons for lack of a release plan. We think this body should pause and ask whether these cuts will save more money than expediting release plans for the 300 individuals who cost about $20,000 per person per year to be housed in Nevada prisons. Also, a two-year delay of these individuals and others who may get stuck waiting for release after parole grant would likely cost more than the cuts proposed. So we just wanted to ensure that this was on the record and something for the committee of the whole to consider. Thank you for your time.
Thank you, caller. Next caller with the last 3 digits of 883. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and begin. Caller with the last 3 digits of 884. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes and you are now unmuted and may begin.
Serena Nichols, Sarena Nichols. And I want to thank you for giving me this opportunity to say my piece. I have been a state worker for 11 years. For 4 of those years, I was furloughed and did not receive a raise. And now we're looking at possibly 6 years later doing it again. After those 4 years were up, the body here could have been proactive and tried to figure out how to make a big rainy day fund. Instead, we gave away billions in tax incentives to companies to come here who promised good jobs. Those good jobs never came out. They brought people from out of state. We had a housing shortage for a while, and now rent is sky high. I'm worried that this body is not really looking at how they can be proactive. They just seem to be reactive when we have something go bad. This COVID obviously isn't anybody's fault, but it's clear that Nevada needs a new way of looking at our revenue stream. We have to be proactive. Instead of looking at ways to bring in revenue, during the good times, we gave away money, we gave away billions, including to Tesla and including to the Raiders. We bought 2 new big state planes. I'm urging you to look at ways to be more, to get a revenue stream. If that means taxing businesses, then so be it. They will still come here. They come to other states that have taxes. We need to stop giving away taxes and giving away money. And then when something does go bad, and clearly this is going to be happening more and more. Again, this is only 6 years out from our last recession. Another one could be coming, and then what are we going to do? Cut more and cut more? Then we'll have no services. You'll have no state workers. It'll be awful. So I'm just urging you to do the right thing, make bold steps, and be proactive, not reactive. Thank you for your time.
Thank you, caller. Next caller with the last 3 digits of 892. Please slowly pronounce both your first and last name for the record. You have 2 minutes. You are now unmuted. You may begin.
Hi, just give me 1 second. Sorry about this. I'm calling into assembly with my comment, which I'm pulling up right now. I'm so sorry. So this is a comment that I read for Senate, and I am going to read it for Assembly too, if that's all right. My name is Vera Miller, and that's V as in Valor, and VERAMILLER. I'm 24, and I have they, she pronouns. The burden of the crisis and the burden of sacrifice should fall on all of our shoulders, with equity, meaning those least impacted must take up the most burden. All corporate entities, such as mine and Tesla, should take up this burden. Above all else, severely impacted and marginalized people should take on the least amount of burden and have the most amount of protection. It's wrong to consistently demand of our health and education services to make sacrifices in crisis. It's wrong putting our health and our education on the chopping block first, above carceral entities and above corporations like mining and Tesla. It's wrong, it's wrong, it's wrong. You talk about how hard of a decision it is to make, that you don't have an option, but you do. And I will emphasize this again, you absolutely have the discretionary decision right here. You have the power and the ability to change this. Don't make us suffer, because we will, and we already are before COVID. I would also like to emphasize to you all that we are in the throes of climate crisis, and that COVID is encapsulated in that. We are going to keep running into crisis after crisis, and with this virus, it might be with us longer than we could ever anticipate. The punches will keep coming. Health and education are not optional luxuries that we should just cut away. Again, and I've talked about this before in Senate, I'd like to reemphasize, I want to talk about Micaiah Lee.
Ma'am, you're well beyond the 2 minutes if you can wind down. And if you have anything in writing, feel free to submit it. The same information that provided you with the phone number, you have an email address, you can submit it in for the record.
Of course, I've just got one more thing. I'm so sorry. I'd like to talk about Micaiah Lee.
Ma'am, I need you to wind it down. We have to make time for other people. So I would encourage you to provide it in writing, and we will certainly include it in part of the record.
One sentence left. One sentence.
If I had a button, I would take care of it, but BPS, can we move on?
Absolutely. Thank you, caller. Last 3 digits of 567. Please slowly pronounce both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
This is Cindy Pitlock, CINDY PITLOCK, Doctorate of Nursing Practice and President of the Nevada Advanced Practice Nurses Association. The proposed across-the-board cuts of 6% to Medicaid reimbursement has raised concerns with the Nevada Advanced Practice Nurses Association and how it will affect the state's more than 2,600 licensed advanced practice registered nurses. First and foremost, NAVNA understands the challenges facing our state as it addresses the economic fallout and subsequent budget shortfall created by the corona pandemic. We know the sacrifices must be made and that the legislature has difficult decisions to make. However, we are hopeful that whatever decisions are made minimize the impact on Nevada's most vulnerable citizens. As for the potential effect on APRNs, I think it is important for us to realize that since granted practice autonomy, many APRNs have their own businesses that include significant overhead similar to that of other providers, and we currently do not have parity in Medicaid reimbursement rates. For discussion, I wanted to give you actual real-world numbers for context. For billing code 99204, physicians' reimbursement rate is $162.51, and APRN is 107.77. For billing code 99214, physician reimbursement rate is $105.69.95. So because we already receive far less than parity for the same provided service, if we sustain further reimbursement loss, many of the autonomous APRNs may have to close practice. Thank you for listening to our consideration and have a great evening.
Thank you very much.
Next caller with the last 3 digits of 015. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hello, my name is Courtney Brothers, COURTNEY BROTHERS, and I was calling to comment on cuts to funding for resources and insurance that covers resources for individuals with autism. Obviously, this is a taxing time on everyone, but it's especially taxing on those with disabilities, especially for people on the autism spectrum that may have a hard time transitioning to these new conditions, such as wearing a mask, which could produce sensory issues, also services being transferred either to online or having to be altered in some other way. The one thing that I wanted to talk about, my main concern, I suppose, is that continuous resources are incredibly vital to people with disabilities. So cutting funding, whether it's going to be used for certain families or not, presents a problem because some people don't have the resources outside. So my main issue would be there's no plan to educate parents on what other resources that are less reliant upon state funding that they can go to. There aren't resources given to parents about what things that they can do for their individual with autism. Thank you.
Thank you.
Next caller with the last three digits of 893. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hi, my name is Bailey Watkins, Bailey Watkins. I would just like to say I understand that there are budget adjustments and unfortunately cuts that need to be made in the wake of COVID-19. And I know that these are very, very tough decisions to be making, but we need to be making sure that we are building a stronger Nevada post-pandemic. And the way to do that is not through cuts to education. They are not through cuts to healthcare, especially mental health care. I urge you to please reconsider, especially the education cuts, especially the mental health care cuts, because especially because those two things have been so severely impacted by COVID already. Our kids are going to be falling behind and needing extra support after this. I'm sure that you don't need to be told that people's mental health has been severely impacted by the isolation of the pandemic. Instead, we need to be taxing mining and Tesla and other very, very profitable industries in Nevada that have the money that we can use, and taking funding from law enforcement and prisons, because it has been shown that funding education and mental health care will reduce crime rates. That is, as has been stated before, a more proactive approach, whereas the funding of law enforcement and prisons is a reactive approach, and we need to be working to be proactive in building a stronger Nevada post-pandemic. Thank you for your time.
Thank you.
Next caller with the last three digits of 906. Please slowly pronounce and spell both your first and last name for the record. You have 2 minutes. You are now unmuted and may begin.
Hello, my name is Elena de la Paz, ELENADE space LA space PAZ. I would like to bring up the fact that we're ignoring that Reno spends 36% of its budget on over-militarized police systems, and in Sparks we spend 42% of their budget on over-militarized police systems. Yet we are not considering the fact that we should be taking some of these funds to divest back into the community, specifically education and healthcare. We're in the middle of a pandemic, and we cannot ignore or pretend that we understand these impacts, because you don't. They do not impact you. They impact the people that you do not see every day. Yeah. I see people on the streets every day, and they might not be there tomorrow, and that's scary to think about, and it's something that we should just separate from our minds, and I think it's fucked up. Yeah. Consider this. Consider it well. Yeah.
Ma'am.
Put your money somewhere else.
Ma'am, I would ask you to.
People up.
Okay, BPS, can we move on? Thank you, ma'am.
Mr. Speaker, that is the last caller. That was the last caller in public comment.
Thank you very much. Where are we? That being the end of public comment, have to go. I think we're still in committee of the whole. Assemblywoman Benitez Thompson.
Thank you, Mr. Chair. I move that the committee of the whole now rise and report back to the Assembly.
You've heard the motion. All those in favor, please signify by saying aye. Aye. Opposed, nay. Motion carries. The Assembly is resolved until the. Oh wait. We are rising and reporting back to the Assembly. Sorry. The Assembly will now come to order. And Assemblywoman Benitez Thompson.
Yes, Mr. Speaker, may we go to Order Business 9, introductions?
Order Business 1.
I'm sorry, Order Business 1 first. May the record reflect that Assemblyman McCurdy is present. May the record also reflect, I think that's gonna.
That's it.
Thank you.
Record shall so reflect. Assemblywoman Benitez Thompson.
Thank you, Mr. Speaker. May we go to Order Business 9?
Order Business 9.
Assembly Bill 3 enters by the Committee of the Whole, an act relating to state financial administration, reducing certain appropriations and other money budgeted for fiscal year 2020-2021, authorizing certain sums appropriated to the Department of Health and Human Services to be transferred among the various budget accounts of the department under certain circumstances, requiring the transfer of certain money to the State General Fund, revising various provisions relating to the authority for such transfers, authorizing certain expenditures, temporarily suspending the transfer from the State General Fund to the account to stabilize the operation of the state government for fiscal year 2020-2021 and providing other matters appropriately thereto.
Assemblywoman Benitez Thompson.
Thank you, Mr. Speaker. I move that Assembly Bill 3 be referred to your Committee of the Whole.
Without objection, so referred. Assemblywoman Benitez Thompson.
Mr. Speaker, I believe we might have some Order Business 15.
Order Business 15. I apologize, Assemblyman Edwards.
Thank you, Mr. Speaker. I don't think I have to tell anyone sitting in these seats that we're on a pretty fast-moving train trying to come up with solutions to some huge problems that few of us have ever dealt with. I wish I had all the answers to the problems, but I don't. However, over the course of the past few days, as information has firmed up and we've been given numbers and cuts, I've been developing what I believe is a pretty viable solution to help us out. I finally came to a form that would be specific enough to address this afternoon, and that's what I was trying to do earlier. The solution that I was proposing essentially expands upon our experience with opportunity scholarships, because as you know, we had 2,300 students getting $6.5 million at an average cost of $3,000. I thought we could expand upon this in order to free up the resources to help the very people that so many of you talked about yesterday so passionately, the people that we need to help and the people that we're here to help. I believe it's a viable option that we should consider and vote on. I mean, after all, isn't that why we're here? I'm open to any other proposal that comes along to provide the services and the programs. I just haven't heard any others yet. I hope you'll consider mine.
Anyone else under Order Business 15? Assemblywoman Benitez Thompson.
Thank you, Mr. Speaker. Seeing no more business before the body, I would move that the Assembly adjourn and convene on Friday, July the 10th at 9:30 a.m.
You've heard the motion. All those in favor, please signify by saying aye. Opposed, nay. Motion carries. We are adjourned.